So good afternoon and welcome to bill hearings to the House Health and Government Operations Committee. If you have a video on or something I hear, please turn it off. I'm your chairman, Jocelyn Peña-Milnick, joined by my vice chair, Bonnie Collison. This is our first session back in person since 2020, so I ask for your patience if we encounter any technical or streaming issues. Please set your electronic devices to vibrate and don't hold conversations in the committee while testimony is happening because it's distracting. As a reminder, there's no food or drink allowed in the gallery. Please be mindful of, leaving food in the gallery or throwing liquid in the trash because staff has to clean it and it's not right for them, okay, to be able to do that. We are going to hear from the bill sponsor and the bill sponsors panel, followed by an all in-person witnesses. So it's going to go in the following manner: favorable, favorable with amendment, and unfavorable. Then all virtual witnesses, favorable, favorable with amendment, and unfavorable. The bill sponsor testimony is not limited here, but please don't take more than 5 minutes. While all witnesses will have 2 minutes to provide testimony. A timer is displayed on the screen and a sound will be played once your time has expired. Please adhere to our usual committee rules of 1 question and 1 answer from the panel. This is for our wonderful delegates, my colleagues. Now 1 question and 1 answer from each witness. So the bill sponsor, if you will be so kind and look at your panel and decide when the question is asked, who's the best person to answer that question, to address it. Members and witnesses will have an opportunity to engage further discussion about the bill during subcommittee. So even if there are no questions, don't worry about it. Doesn't mean your bill is not good. It just means that, we understand it, we read it, and we even, everything that's submitted in writing is also considered equally as orally. And then most of the bills here, they're discussed in subcommittee, and we have an open process where everyone is welcome to the subcommittee hearings as well. Members of the public will be able to view the live stream of this hearing on the Maryland General Assembly website and YouTube channel. If you see that there's some members that are not here, it doesn't mean they don't care. It's that they have hearings. We are a week away from crossover in other committees, but they listen to the recording and they'll be coming in as well. If you see that I get up, I don't get up often at all. I will sit for 5-6 hours straight. But if I do, it's because I need to go get maybe some water, okay? Doesn't mean that I don't care and someone else will be here taking care of the hearing. The order of the bill is the following: House Bill 774, House Bill 702, House Bill 786, House Bill 977, House Bill 1124, House Bill 1199, House Bill 1217, House Bill 815, and the last bill of the day is House Bill 1151, okay? And I'm going to add something to the script that is not on my script, is that we are a week away from crossover. The bills that we have here, I asked the sponsors to work with all the advocates, try to come to compromise, work on the amendments so that when it is assigned to a subcommittee, it's ready to go, okay? So do the work as well. Let's start with House Bill 774, and that is actually the speaker's bill, it says. OAG is presenting the bill, not the speaker, because it's by request. So good afternoon. And I believe I have Zach Shirley, Lisa Hiley Martz, and I have Stevane Ellis as part of the sponsor panel.
That's correct.
All right, thank you. And how are you? Good afternoon.
Good afternoon, Madam Chair. How are you?
I'm doing well. Thanks for asking. So who's going to start first?
I believe I will. I'll introduce
Okay,
them.
wonderful.
Good afternoon, Madam Chair and distinguished members of the committee. My name is Zach Shirley, and I'm the director of the Maryland Medicaid Fraud Control Unit in the Office of the Attorney General. I'm joined today by Ms. Lisa Martz, Deputy Director of the Medicaid Fraud Control Unit, and Ms. Stevane Ellis, the State Long-Term Care Ombudsman. Since 1979, the Medicaid Fraud Control Unit has been charged with investigating and prosecuting the abuse, neglect, and exploitation of vulnerable adults in Maryland. It is well known that unlicensed assisted living facilities are hotbeds for this type of crime. By virtue of being unlicensed, these facilities operate beyond the watchful eye of the state's Office of Health Care Quality, the agency charged with oversight of assisted living programs around the state. Free from oversight or accountability, the owners of these facilities are free to prey on the elderly and disabled residents, helping themselves to Social Security payments, pensions, life savings, and even food stamps. In exchange, the residents do not receive care nor the attention that they deserve, and they are instead neglected or worse, abused by callous owners who put profits over people. In reviewing the extensive testimony submitted in support of this bill, it occurred to me that what you will hear today from the three panels is a microcosm of how this bill came to be. Stakeholders from all perspectives and disciplines have recognized the active threat posed to Maryland's vulnerable adults by unlicensed assisted living facilities. This bill is the product of a collaborative effort among those stakeholders to create a more robust system of protections against exploitive assisted living facilities. At present, there are over 1,500 licensed assisted living facilities in Maryland, but there is still a tremendous and growing need for affordable care of this type. For this reason, Maryland Code Health General 1809, as it exists today, is focused not on punishing unlicensed operations, but on bringing them into compliance with licensing regulations. So long as an unlicensed facility applies for a license within 30 days of being discovered, they are immune from prosecution. But what history has shown is that some predatory assisted living facility operators will never and should never be licensed. Their facilities are deplorable and the services do more harm than good. In those cases, the immunity from prosecution provides these abusive operations with nothing more than a get-out-of-jail-free card. I'll walk you through the process. You set up an assisted living facility in a home, it's a residence, it's a house. It's not a sprawling hospital-like facility, it's just a house. You don't put a sign out front. You bring in elderly or vulnerable residents and you operate. You operate with impunity because the state doesn't know you exist, so you are not subject to inspection. Eventually, if you get caught, possibly because someone elopes or someone complains, or as we had one case, you don't turn on the air conditioning and someone has a heat stroke and the EMTs come. That's the only way we ever find out these places exist. But when that happens, a report goes to OHCQ. OHCQ comes out and knocks on your door. This is your house, you don't have to let them in. Perhaps OHCQ will call Adult Protective Services, perhaps they'll call the police and have them do a welfare check. If you are eventually found to be operating an unlicensed assisted living facility, you just apply for a license within 30 days, and then you're immune from prosecution for the pendency of the licensing process. And you take advantage of that time to do two things. You change ownership and you move residents to another facility. And the really unscrupulous operators in Maryland own more than one house. So you just move the people who are living in house A into house B. That way, if you're denied a license, it doesn't matter because you're no longer operating. Or if you're denied a license and found to be operating an unlicensed facility later, you can claim that the owner is someone else who's never been denied a license, and this cycle starts again. What you can see is this is a rinse and repeat operation. It's a huge loophole that allows unlicensed assisted living facilities to enact real harm on vulnerable people, and there's no way to get at them. House Bill 774 closes this loophole by subjecting predatory and abusive unlicensed assisted living facilities to immediate investigation and prosecution by the Office of the Attorney General, while maintaining the existing process for bringing well-run but unlicensed assisted living facilities into compliance. It also commands cooperation from unlicensed assisted living operators who at present are under no obligation to allow OHCQ into the facility to determine the state of affairs therein. Finally, the bill provides for injunctive relief in those cases where a facility's continued operation poses a real-time threat to residents' well-being. These three changes will create a new enforcement landscape for unlicensed assisted living facilities and make the system safer for Maryland's elderly and disabled citizens. For these reasons, we urge a favorable report on House Bill 774 with the amendments contained in our written testimony. Thank you.
Thank you for your testimony. Next, please.
Thank you. Good afternoon, Chairwoman and members of the committee. As stated, my name is Lisa Heil-Martz, and I'm the Deputy Director of the Medicaid Fraud Control Unit, which soon to be known as the Medicaid Fraud Control Unit, Vulnerable Victims Unit. The Medicaid Fraud Control Unit is one of 53 in the country, and we pursue healthcare fraud, but we also pursue cases of abuse of vulnerable adults. So this bill is very important to us to close those loopholes so that we can effectuate effective prosecution. A portion of our abuse and neglect cases stem from inadequate and sometimes abusive care in assisted living facilities. It's well documented that there is an insufficient number of assisted living facilities in Maryland to serve the vulnerable adult population, which makes unlicensed facilities both a blight and a necessity in the community. However, this situation places Maryland oversight agencies in an untenable position, as there's no ability to regulate the unlicensed facilities, and the current law as it stands makes it nearly impossible for us to bring these unlicensed facilities into compliance, either through administrative or criminal remedies. One recent case our office investigated revealed the real-time issues and loopholes that the current law possesses. As the statute is currently written, if OHCQ does not have evidence that the facility is unlicensed, it cannot pursue an administrative remedy. And without that action, we like to call ourselves MAFUKU, cannot pursue a criminal remedy and for the operation of the unlicensed ALF, and as the former is required for the latter to occur. This case is regardless whether we have a credible allegation of abuse, neglect, or exploitation of the people inside. Furthermore, and most importantly, the current statute tolls that criminal process indefinitely if the operator either applies for the license to HCQ or moves the residents out of the facility, which is very likely. This is precisely what happened in our most recent case. The bad actor applied for licensure and continued to operate the facility where the evidence showed that the residents were being neglected. We have seen many unlicensed facilities in the past where the operator clearly just moves the residents out, further complicating the issues and delaying our investigation into the possible abuse and neglect of vulnerable adults. The proposed changes to this statute would allow us to pursue criminal action and while also allowing the good actors to apply for and obtain a valid license, striking a balance between protecting vulnerable adults and acknowledging the role that unlicensed facilities play in Maryland. It is for these reasons we urge your support. Thank you.
Hi.
Hi. My name is Stevan Ellis. I'm the State Long-Term Care Ombudsman. I'd like to wish the Chair, the Vice Chair, and members of the committee good afternoon, and thank you so much for hearing our testimony today. The Maryland Long-Term Care Ombudsman Program advocates for residents in nursing homes and assisted livings in Maryland. Ombudsmen work to resolve complaints that can have adverse effects on the quality of care, safety, health, and quality of life of the citizens that reside in these facilities. In Maryland, ombudsmen provide these services to over 50,000 citizens that live and receive services in both nursing homes and assisted living facilities. It is important to consider who lives in an assisted living facility. An assisted living facility is defined as a facility that provides care to two or more unrelated people that need assistance with activities of daily living, such as bathing, dressing, medication. And additionally, many assisted living residents would meet the requirements for a nursing home level of care. For individuals that are Medicaid waiver recipients, which also pays for assisted living, they do have a nursing home level of care. All assisted living facilities are required to have a license. However, the current law is not enough of a deterrent because there are unlicensed assisted living providers. Would you want a family member of yours to receive care in an unlicensed nursing home or to receive care from an unlicensed physician or nurse? I'm sure you would not. The Ombudsman continues to receive information about unlicensed assisted living facilities, and these referrals are made to Office of Healthcare Quality and other agencies. This bill is incredibly important because it will strengthen the current assisted living law. This bill adds additional safeguards when abuse occurs or if the provider does not cooperate with the investigation. In most cases, the unlicensed provider is aware of the requirements of licensure. Ignorance of the law should not ever be tolerated. Ignorance is not bliss. An assisted living facility provider must complete all requirements for licensure to keep their license in good standing to care for residents. Residents must not reside in an assisted living that is unlicensed. Again, would you tolerate a physician or nurse or any other type professional to practice without a license? I really do urge you to support this bill and give it a favorable report. Thank you so much.
Thank you for your time today and for being here, and thank you for the work you're doing. I have just one question for clarification. The amendment that you referenced to is the amendment suggested by the Maryland Association of County Health Officers, correct?
No, Madam Chair, the amendments are at the end of the Office of the Attorney General's written testimony.
Okay, to that one.
I'm happy to briefly describe them if you like.
So you did not mention, those I have, but there's an amendment from the Maryland Association of County Health Officers that actually, have you seen their letter?
Yes, ma'am.
Okay, are you okay with that amendment?
I-
And what they say is that health officers do not have the experience and the staffing to carry out investigations, and they actually suggest the Office of Healthcare Quality, which makes sense.
Madam Chair, with regards to that amendment, the issue that we have with it, where they want that amendment, is where we're asking for injunctive relief. They would not be a party in terms of working on that issue. Myself, Ms. Ellis, attorney generals for both the health department and the attorney generals that would be prosecuting these cases met last summer many times to work out this bill, to hammer out. So I think that letter, well-intentioned as it may be, that amendment, perhaps he did not talk to his assistant attorney general and realizing that our unit, usually because we're tasked with it under the law, would be the ones following the injunctive. And we also have investigators and the resources to be able to handle that.
So because we're so close to crossover, and there's another house, we want to make sure they pass both houses. I need you to talk to them and work this out before, it's assigned next week, okay?
Yes, Madam Chair, and I apologize because we tried to anticipate everything, and that I literally found that out yesterday.
No, it's okay, and I was glad to see that it can be handled with assistant resources, so there's no fiscal note, because at this point, that's an issue too. For some
I
of these
understand.
bills, I know people don't want to hear it, but that was pleasing. Are there any other questions? Well, thank you so much for your work, okay?
Thank
I
you.
appreciate
Thank you very
it.
much.
Oh, you have a question, Delegate Taveras.
Hi. So, thank you, Madam Chair. Yes. No. I'm sorry. In looking at the bill, in discussing the bill with 1199, there was going to be a roster or registry that was going to be created of these people.
You have the wrong bill, I think. 1199 actually is supporting this bill.
No, they are.
Yeah.
Because a registry is being created to try to keep track of these individuals that are the bad actors.
I believe there's another bill that's being looked at with regards to that, but I'm not aware of any registry with regards to unassisted living facilities.
Okay,
Delegate Taveras, that's a different bill.
all right.
That's what
My
I was referring
apologies.
to. It's okay. I mean, that's what we're here for. Thanks. Any other concerns or questions? All right, thank you very much.
Thank you, Chairman.
Thank you. We have the following people. Will you be so kind and come up? Mary Ann Brennan. Schroeder. Sarah. Mickey, and forgive me if I don't pronounce your name correctly. And Eric Koshamiro. All right, who would like to get started?
Good afternoon, Madam Chair and
Good
members
afternoon.
of the committee. I'm Sarah Mirsky-Mickey. I'm the Deputy Director of the Baltimore Jewish Council, which represents the Associated Jewish Community Federation of Baltimore and all of our agencies, including HANA, the Jewish Response to Trauma, Abuse, and Neglect, including elder abuse. We're here today in support of House Bill 774. I have with me Jackie Schroeder, who runs our elder abuse prevention program at HANA, and she will talk about client stories as it relates to this bill. We are really happy that the AG has brought this bill. It's something that we have been working with the past several years with the House and with the Senate around unlicensed assisted living facilities. And I'm really here just to answer any questions you may have, and I will just turn it over to Jackie, and we ask for a favorable report. Thank you.
Good afternoon, Madam Chair and committee members. My name, As Ms. Mickey said, is Jackie Schroeder. I'm the director of the Elder Abuse Awareness Program at HANA, the Abuse and Trauma Agency of the Associated. To date, we've served approximately 900 older victims in Baltimore and other jurisdictions. All elder abuse is hallmarked by a victim's expectation of trust of the person who turns out to be their abuser. Regardless of the type of abuse, all elder abuse is intentional. I want to briefly tell you about a 72-year-old man named Donald who called for help while living in a filthy, bug-infested facility. He ended up there 8 months earlier from a hospital discharge. The hospital had connected him with a placement agency that found him a room in what they called a licensed care home, but it was not licensed at all. The operator of the dilapidated house left residents alone for most of the day while she went to her job and did not feed the residents breakfast until mid-afternoon. The house operator screamed at and punished Donald for complaining by refusing to feed him for days on end. The condition of the home was dangerous. Exits were blocked with stacks of boxes, electric sockets were burned out, and one day the ceiling above Donald's bed collapsed shortly after he had awakened, leaving plaster and debris on all his furnishings and possessions. We also had concern for the other 2 residents in the home. We contacted Adult Protective Services, the Long-Term Care Ombudsman, and the Office of Healthcare Quality. No one could get into the home because the operator had trained the residents to not open the door when she wasn't home. We arranged with Donald's doctor to meet him at the doctor's office, and from there, by request from Donald, we took him to our elder abuse shelter. While in shelter, we were able to help Donald recreate his identity, which he lost while in that facility, and help him move into a senior apartment where today he still resides happily. Having a law that forces an operator to cooperate with the Office of Healthcare Quality, APS, and the police is imperative for holding unlicensed operators accountable when elder abuse is occurring. We urge you to vote for House Bill 774. Thank you very much.
Thank you for sharing your personal story with the committee. We appreciate it. Next, please.
Good afternoon. My name is Mary Ann Brennan. I'm the program manager for the Baltimore City's Long-Term Care Ombudsman Program, which is part of the Baltimore City's Health Department. The Long-Term Care Ombudsman Program advocates for residents in long-term care, and in the city that includes more than 500 plus assisted livings, and the number keeps growing. These are licensed assisted livings. However, through our work as advocates, we receive complaints about residents who live in the unlicensed facilities because there's often a connection between the licensed and the unlicensed facilities through ownership and through management of these properties. The owners of the licensed facilities too often use their license to deceive the prospective resident or a healthcare entity that this resident will be moving into a licensed facility, but when in fact they're moving into an unlicensed facility. The complaints we receive range in gravity to include physical and financial abuse, quality of care, receiving absolutely no care, no staff, and to live in deplorable conditions. I have personally witnessed residents. I have gone to facilities and have witnessed this myself, and so has my staff. And they're living in squalor, they're receiving no care, and yet the owners of these properties, of these unlicensed facilities, have complete control over the residents because they have control over their finances. They are the representative payee of the Social Security check. These residents, though, however, are not independent. They need care, and they are very vulnerable to these predators. Many of these residents are not from Baltimore, even though this is happening a lot in Baltimore. They're not from Baltimore. They're from other jurisdictions. They're being discharged from hospitals or other facilities, but they can't afford to live in their own jurisdiction because they are on a fixed income, which, of course, a growing number of older Americans are. This bill provides an opportunity for relief at the local level, which is so important because at the local level, we are the ones asked to respond and help these residents. The city and other entities can now seek injunctive relief against these unlicensed facilities if this bill is passed. The number of unlicensed assisted livings continues to grow, and we cannot allow this to continue to become a permanent part of the fabric of how we provide long-term care in the state of Maryland. For these reasons and others, the Baltimore City Administration supports House Bill 774.
Thank you, and thank you again for your testimony. Eric?
Madam Chair, members of the committee, for the record, Eric Colchimero, Alzheimer's Association, here in support of House Bill 774. Today, we're really here grateful for the work of the Baltimore Jewish Coalition, the Attorney General, and the Long-Term Care Ombudsman, who are working on this issue in counties across the state. We also hope that one day the Office of Healthcare Quality will be able to meet its mandate to inspect all assisted living facilities. Legislation has been on the books for years now for licensed assisted living facilities. And the Office of Healthcare Quality, despite positions being added every year, is not scheduled to meet its mandate to inspect assisted living facilities until fiscal year 2025. This legislation is not even about assisted living facilities, it's about unlicensed one, and it speaks to the scope of the issue in this industry and the need for consistent quality across it. People with dementia are especially vulnerable to abuse because the disease may prevent them from reporting abuse or recognizing it. People with Alzheimer's gradually lose their ability to find words, express their thoughts, and follow conversations. They have difficulty understanding others, and their communication wanes as the disease progresses. There are well over 1,500, I think the last figure we had is 1,672 assisted living providers across the state. There are also an unknown number of more unlicensed ones. Facilities who care for our most vulnerable Marylanders provide necessary services, yet whether they are inspected or not, the quality of care really can improve. We're grateful to the Attorney General's office for raising this bill, for emphasizing the importance of quality, and thank you for the time.
Thank you, I appreciate you. Are there any questions for this panel? First, I have Delegate Riley.
Thank you, Madam Speaker. I probably, if I would have thought of this, probably the other panel could have answered it better, but maybe one of you might be able to. If not, I can get them offline. So if you find a home that is actually, operating as an assisted living, and I heard the other panel say that it consists of 2 or more patients, and you see that, what does it take to get a license for that homeowner? I see it's in the COMAR, but I can't pull up that. It's not actually in the fiscal note, but if you could just generally, what are some of the qualifications that they would have to meet to get licensed?
The licensing, I can't speak to exact licensing requirements, but they have to apply for the license. And during that time, when they initially apply for the license, they can't operate as a license.
Thank you. Any other questions for this panel? Seeing none, thank you very much for being with us today. We appreciate it. Next, I have another panel, the last panel for this bill hearing, Dana Kaufman, Paul Schwartz, and Tammy Bresnahan. Good afternoon.
Good afternoon, Madam Chair. I won't take long. My name's Tammy Bresnahan. I'm the Director of Advocacy for ARP Maryland, and every time I kind of think about this situation, I just wonder, how can it happen? How can people be living in squalor and being abused and not being let go, and then the state not able to get into their home, and that there's no prosecutorial process? It just doesn't make sense to me. The proposed legislation will strengthen and give teeth to the Attorney General so that bad actors who are doing bad things in assisted livings or unlicensed assisted livings, as this bill says, accountable. For years, ARP and other advocates have been ringing the bell about bad actors in long-term care. Passing this bill will give the state another tool in the toolbox to prosecute those bad actors. We ask you for a favorable report on House Bill 774. Thank you.
Thank you. Next, please.
Thank you very much, Madam Chair, members of the committee. My name is Dana Kaufman. I'm here in support on behalf of Lifespan Network, which is the lead provider association representing assisted livings. I do appreciate the comment that was made on the previous panel that this bill isn't about assisted living programs. It's about those who are operating without any type of regulatory oversight. And as an association, we are very concerned about that and the effect it has on the entire industry. We do believe that this bill strikes the necessary balance between those bad actors and those who simply need to understand more of what they're doing. Again, as you heard, the assisted living industry is one size fits all. 2 individuals, 250 individuals. They all live under the same regulatory structure. And 72% is 9 beds and under. So we really do need to have more assisted living programs. We just need them to be licensed and understand the regulatory environment that they exist under. So with that, we would support we support the bill and urge a favorable vote.
Is Paul Schwartz for NARFE here? I don't see him. Are there any questions for this panel? Delegate Taveras.
I'm sorry.
Yes.
No, thank you. I think I just had a brain fart. Sorry. Getting older.
No, it's okay. It happens. Forgive us. It's that time of session. People are tired, and we're having long days. So forgive us. There are no more questions. Thank you very much.
Thank you.
This actually concludes the bill hearing on House Bill 774. Oh, in any event, I have an announcement for the committee. Did anyone pick up a pair of glasses that were left in the back? They belong to Delegate Hutchinson. Did anyone pick them up? If you did, can you make sure he gets it? Because I know what it's like when I don't have these on. If I don't have these on, I can't read. See, this is wonderful. Thank you. Anyway, next we have House Bill 702, Delegate Kerr. Healthcare facilities, nursing homes, acquisitions, and licensure.
I was wondering why I couldn't read.
See, this is a fun committee, right? Go ahead. Ooh, something is in the air.
All right, well, good
Delegate Kerr.
afternoon. Yes, my name is either Ken Kerr or Ken Carr or Ken Care. And I think today, since we're talking about nursing homes, I'm going to go with Ken Care.
Okay. And let the record reflect that it was not the chair who mispronounced your name, it was yourself on a prior hearing, okay? So, but you can go ahead. Actually, on your panel, if I may, you're supposed to have Sylvain Ellis, Claudia Backlog, Tammy Bresnahan, Eric Colchamero. Eric, I don't know, after knowing you 17 years, why today I'm tongue twisted. Okay, go ahead.
Thank you. As I said, my name is Ken Care. I'm here today with House Bill 702, Healthcare Facilities, Nursing Homes, Acquisition and Licensure. So Mahatma Gandhi once said, "The greatness of a nation can be judged by how it treats its weakest members." There are a few of us in here who are of an age that we would have read Pearl Buck's The Good Earth in high school. And in that she wrote that our society must make it right and possible for old people not to fear the young or be abandoned by them. The test of a civilization is the way it treats its weakest members. People over 65 years old have about a 70% chance of spending some time in a nursing home, and there are 1.25 million Americans living in nursing homes. The nursing home industry is a $146.9 billion with a B industry with a growth rate approaching 4.5%. So today we're here to discuss acquisition practices of Maryland nursing homes and their ownership and how we can bridge the gap from ownership to excellence. Relatively few nursing home residents are under age 65, and over half are over age 85. These are people who are unable to care for themselves and need round-the-clock assistance. These are our weakest members. So how would Gandhi judge Maryland by how it treats its weakest residents? This bill will require MHCC to collect and provide information regarding the acquisition of nursing homes and require the Secretary of Health to consider this information before taking action regarding licensure. So what we request is a robust subcommittee hearing leading to a favorable report. Thank you, Madam Chair. I'd like you to hear from my panel.
Who would like to get started? Thank you, Delegate.
I can start.
That would be great. Thank you.
Thank you, Madam Chair, Vice Chair Cullison, members of the committee. My name is Claudia Balog. I'm the Assistant Director of Research of 1199 SEIU, representing thousands of healthcare workers in Maryland. We're here in support of HB 702 and urge the committee to issue a favorable report. So our members in nursing homes can attest to declines in the quality of care when some owners, those who are driven by profit, try to cut corners to save costs. They may eliminate housekeepers or food prep workers. They may slash the vacation time or health benefits of their workforce. This only serves to exacerbate the short staffing crisis that we all know and care about in long-term care. Now, the Maryland Healthcare Commission currently reviews the ownership history of acquiring entities. In the last year, they've identified over a dozen owner applicants with potential red flags in their quality track records. Creating a stronger formal process for the Maryland Healthcare Commission to work in coordination with the Office of Healthcare Quality, who issues a license, will help. And it sends a strong message to out-of-state owners that their quality track record matters in our state. Now, we are experiencing in Maryland a record pace of change in ownership. We are one of the top 5 states with the most industry churn, as they call it. If we address changes in ownership, this actually benefits our whole health system. There's a lot of evidence to show that changes in ownership impede collaboration between skilled nursing facilities and hospitals. That makes reducing hospital readmissions so much more challenging. And it also impacts our state's Medicare waiver. I just want to close out and thank the leadership and staff from both the Maryland Healthcare Commission and the Office of Healthcare Quality for their engagement and collaboration in this effort to better protect nursing home residents and staff. 1199 believes that these kinds of guardrails, like are being put forth in HB 702, can be an important tool to address quality of care, and we urge the committee to issue a favorable report. Thank you.
Your timing was excellent. Let's see if you could follow that. Tammy, can you do that?
Oh, sure, I can probably, I can do that. Don't
Go
start the
ahead.
clock yet.
All right.
No, go ahead. Good afternoon, Madam Chair and members of the Health and Government Operations Committee. Again, I'm Tammy Bresnahan. I'm with AARP Maryland, and Delegate Kerr and Claudia, you know, I started checking off the paragraphs, so you have my written testimony. But what I'd just like to leave you with is that AARP believes that intra-agency cooperation is a must. Open book policies of transparent around all data related to nursing home licensure, performance, and quality that is used in monitoring, oversight, licensure, quality, even being, acquisitions, should only benefit, and the welfare should be available, and it should be available to all state agencies. So again, we ask you for a favorable report on House Bill 702. And we thank SEIU for bringing us into their Coalition for Caring. And this is all about making sure that people are safe and that they're getting the services that they deserve. Thank you.
Look at that, we're more than a minute. I have a York for you later. I'll give it to you.
I'm coming.
Go ahead. Who's next?
Oh, sure.
Eric Colchamiro.
Wow.
Go
Thanks.
ahead.
Madam Chair, members of the committee, for the record, Eric Colchamiro, Alzheimer's Association. Here, grateful for SEIU and Delegate Kerr for working together to introduce this legislation, and here to echo some of the comments you've heard in support of House Bill 702. And I think the thing I would emphasize in my testimony, which can't be emphasized enough, this is a big business. Nursing homes are not like assisted living facilities where 75% of them are 9 or fewer beds. This is a big business. This legislation looking at transfer of ownership is important because nursing homes in Maryland are being bought by real estate investment trusts. They're being bought by companies like the Porto Piccolo Group, who bought more than 20 nursing homes during the coronavirus pandemic, leading to disruptions of multiple facilities that weaken care for vulnerable residents and the worst healthcare crisis in generations. The Maryland Healthcare Commission has looked at this. Their review has shown that that those acquiring these nursing homes wouldn't be able to get them through the normal process, through a certificate of need process. How many transactions have their processes deterred in the transfer ownership? It's a question for the MHCC, but I would say very few. It is so important to look at this $146.9 billion industry that received over $100 million in COVID funding and understand that they are providing essential care for those in need, but these are not small mom and pop owners. These are large entities. These are real estate investment trusts. And this bill, which facilitates a better review process, is necessary. It is essential. And I ask for a favorable report.
Thank you very much. Next, please.
I feel like I should just say ditto. But my name is Stevan Ellis. I'm the State Long-Term Care Ombudsman. I'm the advocate for nursing home residents and assisted living residents in Maryland. We have many facilities that have had change in ownership in the last few years. And often these nursing homes are part of a nursing home company or chain that have acquired nursing home licenses in the state. How are these providers vetted prior to licensure? And I do believe that additional information would be helpful, as my panelists have said. For many years, the Ombudsman Program's #1 complaint in nursing homes was discharge and discharge-related to complaints. For the last 3 years, however, the highest number of complaints have been related to nursing home care, and our nursing home complaints, our overall complaints, are increasing. In fiscal year 21, we had 3,711 complaints, and in fiscal year 22, we had over 4,000 complaints. So our numbers are increasing, and then for the last 3 fiscal years, care has been our #1 complaint. And I do believe that is in part related to all of these nursing home company changes. When a nursing home comes in, they make changes across the board, and they make changes across the board in all of their nursing homes. So usually we see a pattern in one, we see a pattern in all. And often these changes are related to care. We see lack of continuity of care when companies come in and change, lack of staffing, lack of individualized care. And I'm very worried about nursing home residents right now, more worried than I have been my entire career. And I've been an ombudsman for 18 years. So I just want you to think about that for a minute. We are very concerned about the quality of life. We're concerned about their dignity. And I'm also concerned about staffing as well and their well-being, because if staff leave, good staff leave, then the residents aren't going to get good care. I'm hoping, and the Ombudsman Program is hoping, that closer scrutiny of nursing home companies that do business in Maryland will prevent these and other care concerns. Like my colleague Eric Colchimero, I'm concerned about the REITs and the private equity companies that have a financial model rather than a care model, I believe do not provide good care for residents. I really do ask the committee to consider my comments and offer a favorable report for this bill. As an aside, I didn't submit written testimony for this. I did for the Senate bill tomorrow, and I have references if you're interested in seeing some of the research that's available and information on change of ownership. Thank you very much.
Thank you, and thank you for the work you do, and thank you for sharing your personal experience, okay? It does matter. As well. So I'm going to open it up now for questions. Are there any questions for Delegate Kerr and his panel? Delegate Johnson.
And thank you, Delegate Kerr, for bringing this bill and your panel. We've talked about companies coming in, investment companies coming in and buying the nursing homes. What is the vetting process when they purchase a nursing home, or is there any vetting process?
I could take this one. I'm not going to speak on behalf of the Healthcare Commission, but the Healthcare Commission does as thorough a review as possible on these owners. Now, there's an issue of transparency. Sometimes it's obfuscated who actually owns these homes, but to the extent of the information that's currently available, they will review the ownership track record. So, we've looked at reports from the Maryland Healthcare Commission that will show, they'll identify this owner is coming into the state seeking to buy 5 nursing homes. We've noticed that they have CMS one-star facilities in other states. We notice that they have a facility that might be a special focus facility or on a CMS watch list. We've noticed that these owners have a quality track record that could be concerning in another state. So that information is already being collected to the extent that it's available from what we can discern. And this bill, I think, is creating just a more formal process that this information isn't just being collected, this information is being used when that transfer of ownership moves on to licensure.
My pleasure. Delegate Taveras.
Thank you. Thank you, Madam Chair. So now, what happens if a pre changes their name? So my concern is you could move from state to state and change your name and start fresh with a clean slate, despite the fact that you've had. So how do this bill handles that?
So I'll take a stab at this one. So when owners are submitting their materials to the Maryland Healthcare Commission, there's information on the application that is supposed to address, who are the facilities you own. It should include their out-of-state operations if they're operating under another name, and whether it's the individual owners or the ownership entities, there are ways of tracking down who owns multiple chains. I do want to note that the Biden administration has a rule that is being promulgated right now. They're seeking comments on it that would improve the reporting by skilled nursing facilities and chains and ownership. And this rule couldn't come at a better time. If we can pass legislation like this, then we can imagine that when state regulators are able to collect better information about ownership, are those owners connected to private equity interests? Are those owners real estate investment trusts? Then all of that data that the federal government has acknowledged needs to be collected in a more methodical manner with more transparency, I think we really get somewhere.
Thank you. Delegate Bagno.
Thank you, Madam Chair, and thank you for bringing up the Biden rule, because that was actually my question, is how will this bill coordinate with data sharing between the states and the feds and vice versa?
We're hopeful that the new rules that will come out on HHS on transfer of ownership will really work in tandem with efforts like this. Like in our minds, if the state regulators receive better quality information, we're in a much better position to put up a guardrail like this bill and really understand who are these people that are coming to the state to buy nursing homes, and are they owners or acquiring entities that we want to see doing business here.
Yes.
So potentially, we could also be establishing a framework for that other states could then model.
I haven't done a state scan. Every state has an idiosyncratic process on on transfers of ownership and licensure, right? But I think that there is a model to be placed here, right? That we're being very intentional connecting somebody's prior history and their quality track record with how we believe they may act in the future, and that their quality actually matters.
Delegate Rosenberg.
The sponsor, you mentioned Gandhi and you referred to her robust subcommittee process. I don't know what Gandhi would think of the subcommittee process, but my question is, I thought one of the witnesses said that Maryland is one of the highest incidences of purchase of these facilities. Why? Why is the problem so significant here?
Yeah, I'm not sure why Maryland has more purchases than other states, but we do. Maybe there's something attractive for the companies that are coming in buying them. And I suspect this would help with protecting the rights of residents. And if there's more vetting that's done, I think perhaps it would attract companies that are less inclined to be private equity and real estate investment trusts. And maybe right now there's not enough protections right now, and that's why. Because we have one company that has purchased or has licenses, and now they're the largest chain in Maryland. And I believe they're a private equity company. But it's hard to find out because that information is not very transparent.
Delegate Hill.
Thank you, and I apologize for missing the first part. I've checked with my colleagues, and I don't think this was addressed, so I don't think I'm being duplicative. When we're asking for the quality ratings, this doesn't say over the last 5 years, 3 years, 2 years. Why are we just saying give us a quality rating and not specifying a period of time where we want to see the track record?
I apologize for the delay. I'm actually reading some of the amendments that have been submitted, and all of the amendments, to my knowledge, that have been submitted are trying to address issues like that. Like, can we make this stronger? Can we improve the scope of the review? Can we improve even the scope of review going beyond CMS star ratings, right? Like, can we look at whether there are lawsuits or arbitration filings? So I don't have a direct answer on like the 5-star, are we looking at 3 years or 5 years? But I will say that the amendments that I've seen submitted on this legislation address scope and in a great way.
Are there any other questions for this panel?
Madam Chair, if I may have a,
We can,
sorry. I was just
sorry, because
give-
we'll be going back and forward.
Oh, no, I was
okay?
just going to give a thank you to Delegate Kerr.
Oh, absolutely. You could give a thank you to Delegate Kerr, yes. Go
I
ahead.
just wanted to mention, along with introducing this bill, a number of elected officials serve on task forces or working committees in the interim. This is far beyond a 90-day job. And Delegate Kerr, along with former Delegate Bel Castro, have served on the Oversight Committee for the Quality of Care in Nursing Homes and Assisted Living Facilities throughout the pandemic. And we're just grateful, speaking from the Alzheimer's Association's perspective, for his service in bringing the bill today, but also the many conversations he's had with industry, consumers, and a number of stakeholders far beyond today.
That is really beautiful and very kind, and he's very deserving, because this is more than 90 days. Thank you.
Thank you.
Thank you so much. Next, we are going to hear from Dana Kaufman, Diana Jarek, and Ben Steffen.
Delegate Rosenberg, our subcommittee meetings are largely peaceful, so I think Gandhi would approve.
So good afternoon. Who would like to get started? Why don't we start with Ben Steffen? Favorable with amendments.
Thank you, Madam Chair, members of the committee. Ben Steffen. You've heard the Healthcare Commission mentioned a couple times in the previous testimony. I want to confirm that, yes, indeed, as part of an acquisition, the Healthcare Commission does a determination that a CON is not needed. It primarily focuses on whether the purchaser is planning to expand the beds or services offered at the facility to be acquired. In 2018, we did add some additional requirements on the specific character and fitness of the purchasers themselves regarding prosecutions or nolo contendere settlements, so that we would have some information on the individuals that are acquiring the facilities in cases where there was a derogatory action. We believe we have the authority to intervene. However, that has not occurred, but as the previous panel noted, over the last 3 or 4 years, acquisitions have picked up in pace. I can give you 3 reasons why that's happened. Maryland's cost per beds are growing, the cost as measured by price per bed is escalating. It's due to, one, in Maryland, we have very low Medicare Advantage penetration. That makes it attractive for nursing home operators to operate in a state when Medicare Advantage is not an active participant. 2, we have relatively favorable Medicaid payment rates, especially relative to some of the Medicaid nursing home rates in other states nearby. And number 3, we have a relatively prosperous retired population, meaning that we are attractive and self-pay is significant. We support this bill. We are offering an amendment that would include, give us some additional oversight on conversions or acquisitions when that acquisition involves a facility with triple and quad beds. It goes without saying that that's an additional risk to patients, and that's been demonstrated over the pandemic. I would leave you with one fact. When there is an acquisition, healthcare or otherwise, we think of 3 beneficiaries. 1, the purchaser. 2, the seller. And 3, the customer. As you've heard in the previous panel, oftentimes the customer is left out of this transaction. We want to strengthen our oversight, have a stronger message from the legislature for the department when appropriate to take action. We support this bill and encourage a favorable response with the amendment that we've submitted. Thank you.
And thank you. I want to thank you, Ben, for your partnership with this committee and for helping us with a lot of our bills and for your work. Next, please.
Thank you.
Good afternoon. For the record, Diana Jarek from the Public Justice Center. I'm here in full support of this bill. There isn't too much more to say that hasn't been so eloquently described by my former panelists, so I'll be quite brief and just say that the Public Justice Center is part of the Caring Across Maryland Coalition, and both are in strong support of this bill that would largely just increase transparency. We're obviously concerned, as Delegate Taveras pointed out earlier, about the opacity of the private equity structures that are trying to invest in our state in the nursing home facilities. And so we strongly support this bill and am available to answer any questions that have not yet been answered. Thank you.
Dana, follow that.
I will try. For the record, Dana Kaufman on behalf of Lifespan Network. We're also in support of this bill. We brought concerns 2 years ago about change of ownership, so we're glad to see that it is going to be examined. However, I do want to just point out a couple issues. So we've heard a lot about the Maryland Healthcare Commission, but the Office of Healthcare Quality is the licensing authority for nursing homes, even those nursing homes who are undergoing a change of ownership. There is a dashboard located on the Office of Healthcare Quality that on the left-hand side shows the application and what must be submitted. And that includes compliance history. It shows ownership. So I just want everybody to be aware that there are 2 entities now, and the Office of Healthcare Quality does have an application. So we do think that this bill helps to tighten that relationship between the MHCC, who again has the authority over their certificate of need, as well as the survey agency. With regards to the question about why Maryland, why do we have so many right now, I also just did want to point out that Maryland had 2 very large national systems, Genesis and Manicare. Those facilities underwent a corporate structural change, and many of those facilities have now been bought in Maryland. So that is also one of the reasons I think that you are seeing Maryland having such a higher rate of change of ownership. I think at one time, Genesis owned 37 nursing homes in the state. So just be mindful of that also may be one of the factors. So with that, thank you.
Thank you for your testimony. Appreciate it. Are there any questions for this panel? Delegate Kaiser.
Thank you, Madam Chair.
Rosenberg.
I have a question for Ms. Kaufman, and it may have been referenced before. You used the phrase change of ownership, and I think someone else may have mentioned before something with LLCs. And maybe if I didn't hear it, I guess I'd still ask the question. Sometimes the change of ownership is in name in some way where the LLC might still be the main, one person. So do you all have a strategy or idea of how we could figure out if someone just keeps changing the name of their corporation or their LLC to mask that there's a problematic owner or person involved?
Well, I know when there is a change of ownership, which is known as CHOW, so it's a CHOW dashboard, there is a documentation that has to be submitted on any ownership of 5% or more. And you can go on to the website and look. So I think that's kind of where you get the distinction. It's a 5% or more. It's not just changing a name, but it does go down to the ownership.
Thank you, Delegate. Delegate Rosenberg.
Mr. Steffen, in the Gandhian tradition, we like our subcommittee meetings to be nonviolent. So I assume you've discussed your amendment with the bill sponsors?
We have discussed it with the bill sponsor, yes.
And they're okay?
They're okay, I believe. Yes, he's here. I asked him to confirm.
Thank you.
Yeah, Delegate Kerr cares about his amendment, right? Thank you very much. I don't see, is there a question? I don't see any others. I thought Delegate Chisholm, you were about to raise your hand. Yeah? I saw the hesitation there. Do you want to ask a question?
But it's very complex, though, because if we're talking about REITs, a REIT, you have to have at least 100 owners in a REIT. So how difficult is it going to be? Because now you're going to have to go through SEC and all the other financial safeguards that are in place. And so my point is, they can transfer and ownership can turn over very quickly. Has this been, I guess, tried in any other state? This is a very complex problem to solve when it comes to changing ownership, when you're talking about a REIT owning all of these.
Who's the best person to address
So,
that?
yeah, I will. I mean, I think the scope of the review is not just on ownership. There's been a lot of discussion on the quality performance, which is a little bit more straightforward to address. I agree with you. Sorting out ownership, especially in nursing homes, is not for the faint of heart. I absolutely agree. But but they do leave a trail. And that trail is the quality reports that are available on the CMS website, on the MHCC website. Our convention is that we look at performance over the last 5 quarterly refreshes. So to the question earlier, this is as current performance information as we can get. What we have been starting to do as a result of commissioner questions is, what is the quality performance of the entity in other states? And that's where we find that in many, many cases, if they had come to us for a CON under our state health plan for nursing homes, they would not qualify. Our commissioners have said, well, we should be applying these same standards for acquisitions. We do currently share that information with the Office of Healthcare Quality. Should this bill pass, I think this would give additional encouragement, when appropriate, for OHCQ to consider other actions beyond automatic licensure.
My pleasure. Glad you asked the question, Delegate Bandari.
Thank you, Madam Chair. I would love to have your wisdom here. What are the potential benefits if we enacted this bill into law in terms of increasing transparency and communication between state agency in licensing, and how could this help improve senior care in our state?
So one thing I would say is it's rare that Ms. Kaufman and I appear on the same panel. So that may be an attestation in itself that we do believe that responsible owners in the industry are supportive of this. And I think should this pass, it would send, and my hope is this would be sufficient, it would send signals to private equity and other purchasers that if you come to Maryland, we're going to look a little more carefully at your track record elsewhere. I think there's more that probably needs to be done, but that I think should wait until work groups over the interim or over a longer duration can look at what else can be done to support the evolution of the nursing home industry in Maryland. I would note that HSCRC has convened a number of panels to look at how there can be closer collaboration between nursing homes and hospitals as we all struggle to meet the tough requirements under the total cost of care model that we've embarked on with the federal government.
Delegate White.
Thank you, Madam Chair. Dana, you mentioned something about the Office of Healthcare Quality and their role in this. And Ben, I was wondering if you could expound upon the relationship and the roles of these two entities and how that would, how they would either work together or collaborate on this. Or maybe Dana, you could expand upon that further.
I think that they each have distinct roles, but that needs to be mended together or melded together. So the Office of Healthcare Quality is actually the designated licensing agency by CMS. So they have the main authority. The Maryland Healthcare Commission reviews as it relates to the certificate of need, which is necessary to be able to operate the nursing home in the state as well. So they're both collecting information as it relates to those two silos. So I think what this bill is trying to do is formalize that process for increased transparency and communication between the two.
You're welcome. Any other questions? Seeing none, thank you for your patience, okay? We really appreciate it. This actually, this completes the hearing on House Bill 702. And now we have Delegate Gazzoni, House Bill 786, Electronic Health Networks and Electronic Medical Records, Nursing Homes Release of Records. And you can come up, Delegate, with your panel. And you have Scott Rifkin, Bill Castelli, Ben Steffen. Ben, you're on this bill. Sorry, I thought you were gonna leave, but you're on. And Stevan Ellis. If all of you can come up with the delegate, that would be wonderful. Delegate, whenever you're ready.
Good afternoon, Madam Chair, Madam Vice Chair, and members of the Health and Government Operations Committee. I'm Delegate Pam Gazzoni, representing Howard County's District 13, and I'm here in support of House Bill 786, Electronic Health Networks and Electronic Medical Records, Nursing Homes Release of Records. I am going to lay some groundwork and let the other folks on the panel here share their expertise after I do that. So starting off, the Maryland Healthcare Commission has designated CRISP as Maryland's statewide health information exchange. CRISP offers tools to improve the facilitation of care for the region's healthcare providers, including nursing homes. Nursing homes contract with electronic health networks, or EHNs, to manage the electronic healthcare record transactions of patients within their facilities. By law, these records are provided to CRISP systems for certain purposes, including a state health improvement program. Federal law protects the patient's records and makes them available to members of the care team, with the residents retaining ultimate control over their data and its release. Nursing homes can direct the electronic health networks to release electronic medical records to business associates of the nursing home. And as an example, and for the purposes of this bill, the business associates are data mining companies that analyze nursing home electronic records and help to prevent hospitalizations as a result of being able to spot emerging illnesses before they reach the point where hospitalization is needed. In addition to preventing hospitalization through improved patient care, these efforts also obviously create significant cost savings to the state, particularly through Medicaid. A pilot program recently conducted in Montgomery and Anne Arundel counties has shown this type of coordination of care to be very effective. During the pilot, the rate of hospitalization dropped by 25%. The program is now being expanded statewide, and consistent access to the data is critical to maximizing its positive effects. Unfortunately, the EHNs that work with nursing homes have created barriers by not releasing data in its entirety or in a timely manner, and some are trying to charge fees for the release of this data. This bill makes clear that chosen partners of nursing homes within Maryland should have unimpeded access to patient data contained within the EHN. HB 786 ensures patient data flows appropriately to key partners in the continuum of care. It will reduce the instances of hospitalizations for that population and improve quality of life. It will also lead to financial savings. For these reasons, I request a favorable report on HB 786.
Thank you, Delegate. Who would you like to go next?
I think I'll take it next.
Please.
Thank you, Delegate Gazzoni, and thank you, Madam Chair. Appreciate you taking the time. We're obviously in support of Bill 786. My name is Scott Rifkin. I'm a local physician, and I've been involved in every possible part of the healthcare system in general, but nursing homes in particular, over the last 30 years. We've been part of the program that Delegate Gazzoni mentioned with the Health Service Cost Review Commission originally creating a grant for 6 hospitals in the state to work with their nursing homes, then put a group of nurses at a central location to look at data coming out of the medical record systems and pointing out to the nurses when Mrs. Jones hasn't had a bowel movement in 3 days because that patient's septic 3 days later or has a history of heart failure and is gaining weight, and looking for all those particulars. That, as Delegate Gazzoni said, resulted in a 25% drop in hospitalizations and a 6% drop in total cost of care, which are remarkable numbers. The state then decided to fund this through CRISP, and CRISP went out and hired our organization and others to work with them to put this out. 120 nursing homes in the state have already signed up. Program just started in November. 120 out of 220 have voluntarily signed up. This bill is meant to protect the ability of legitimate users of the medical record to get that data and interact with that data and work with the care team. There's been a bit of confusion around the issue of business associates, which is mentioned in this bill, and it is a technical term out of HIPAA. And that's not the plumber and the electrician that work at the nursing home. They're not business associates in that sense. They are members of the healthcare team. And the nurses that we have in this particular program are clearly part of the healthcare team. Nobody can say otherwise. And so we're thrilled to support this. There are some federal protections in place, HIPAA and cures, and if there are questions about that, I'm happy to have the talk about how they interact. I will note that HFAM and Lifespan being the 2 biggest organizations in the nursing home world, along with the Healthcare Commission, who's going to speak they're going to speak in a few minutes, and CRISP have all been supportive of this. So thank you.
Thank you. Next, please.
Thank you, Madam Chair. Bill Castelli, also on behalf of Realtime. And I did want to point out a couple of points. One, the legislation we do view as very consistent with the Cures Act. There are some exceptions under the Cures Act in terms of charging for fees, but there are exceptions to the fees exception that clearly lay out that if you are part of that care team, then you should not be charged a fee, so the patient who has already paid for that electronic medical record through Medicaid is charged again to get access for that for their care team. So we do believe this is consistent with the Cures Act, and we would encourage a favorable report.
Thank you. Next, please.
Hi, my name is Stevan Ellis. I'm the state ombudsman, and I appreciate you all hearing our testimony today. I'm supporting this, but with amendments. Nursing home residents are entitled to be informed of their rights upon admission and throughout their stay in the nursing home. The facility has the responsibility to ensure the right of privacy of all medical records. This right should be explained upon admission and when possible prior to admission. Additionally, this right should be provided in writing and verbally. This includes the disclosure of when medical records are disclosed to other parties. The resident or resident representative should provide consent for all release of resident records. And in my written testimony, I cited the federal nursing home regulation. I'm just going to mention a couple parts of it. The resident has a right to personal privacy and confidentiality of his or her medical records, and the resident has a right to secure and confidential personal medical records. I'm proposing a couple of amendments. Number one, and I understand this has been fixed, the citation for business associate needs to be corrected. It should be 160.103. And additionally, when the facility has a business associate as defined by federal regulations or wants to share any additional information, even with a business associate, this information should be included in the admissions paperwork, any disclosure statements, any other documents, so that the resident or resident representative can consent to the release of their medical records for this purpose. I ask the committee to consider my comments and amendments suggested for this bill. Thank you very much.
Thank you. Ben Steffen?
Ben Steffen, the Maryland Healthcare Commission. I am here to just briefly say that we are supportive of this legislation. As Dr. Rifkin stated, last year in legislation that was passed, the state made a commitment to better connect for public health and surveillance purposes, information flowing from nursing homes. He is well on his way to achieving the goal of connecting all 230 nursing homes. The information that would be exchanged does include administrative transactions that pass through what are called electronic health networks, as well as information that flows through electronic medical records, a different entity, very close, but really they use different, they transmit different types of information. We think that it's altogether appropriate that this information for care management and public health purposes go forward. And I think this legislation clarifies that it is appropriate and the authority under state law is established and there is no conflict with federal HIPAA or CARES Act requirements. Happy to take any questions.
Thank you. Are there any questions from the committee? I see Vice Chair Collison.
Okay, thank you, Madam Chair, and thank you all for the bill. So there's the pilot in 2 counties, right? Have there been any issues with security of data or with patients? I'm looking at some of the unfavorable comments, and those are the concerns that they're having. You know, the autonomy of the patient to opt in or opt out, the security, you know, HIPAA violation, potential HIPAA violations. So the pilot's been, am I correct, it's been operating for a year? And the question is, how is it going, and are we running into any of those issues?
Sure. Can you all hear me? I'm a little away from the mic. You able to hear me back there?
We can hear you.
I've got a loud mouth, so I apologize. There have been no problems at all. And I think that's a bit of a smokescreen in general. The issue on patient being informed, I think, is great. And there was, but the issue on security has just been a bit of a smokescreen. There have been no issues at all. Everybody involved is HIPAA compliant. Everybody involved has signed and taken the education required. And in addition to CRISP, where there's never been an issue, the main vendor to that, which is real time, has a level of certification called high trust. High trust is the highest level of certification in healthcare that you can possibly get. And I don't know that the EMR companies themselves have that level. They'd have to tell us. But you don't get higher than that. And so it has not been an issue. I don't expect it to be an issue. And we're constantly on the alert for those things. Thank you.
I have Delegate Hutchinson.
Thank you, Madam Chair. When I can see you guys too, which is good. I'm very interested in this because this is sort of my background in healthcare analytics and data collection, and historically, lack of nursing home data was pervasive. So to see that this is out there is fantastic, and see that you're getting results. And I'm just perplexed that we have to have legislation to force them to release this data to you, because aren't there even components of the CARES Act, the High Tech Act? You have a business associates agreement in place. It's a meaningful use program. I mean, what's the issue that they're not giving it up other than being stubborn?
I think it comes down to dollars. You know, and I think the problem is that the chart, not the problem, the good thing is the chart and the medical information belongs to the patient. It doesn't belong to me, it doesn't belong to the care team, it doesn't belong to the EMR company. The Cures Act makes it very clear that they can't charge fees and do things if it acts as info blocking. And yet it still happens. And it's still happening that affects programs like ours. And so we really want to be, and part of the problem with the Cures Act is final regulations, and some of it haven't come out yet. So we want to just make sure there's nothing that contradicts those acts. This just strengthens what was in those rules. We have a chance to have the greatest nursing home system in the country because of the waiver. And Ben and I and others have been talking about how do we coordinate between the nursing homes and the hospital systems to do that, and to give the right incentives to everybody that's been involved. You have to have data, which you just mentioned a minute ago. And this brings all the data from every nursing home in the state together. We know by unit, by day of the week, by doctor, by whatever, readmission numbers and how they do, a facility does with diabetes and hypertension and everything else you can think of. And those are all pieces of data we can work with the nursing centers so they provide better care. This program grabs that data, decides which patients are about to need to be admitted, and then contacts that nursing home and says, not only Mrs. Jones has a history with heart failure, and I apologize if anybody's last name is Jones in the room, but Mrs. Jones is going to be admitted for heart failure, and we could treat with $1 worth of Lasix and avoid it, but also gives them what the protocol is, the Amden Interact standard national protocols, gives them those protocols to then follow. And that's why we've had the test project was a 25% reduction. The statewide project has only been up for 4 months now, and maybe there's an early adopter effect, but we're somewhere around 45% in reduction. And now that seems too good to be true, but there have been lots of national studies that show up to 60% of admissions from nursing homes are avoidable. And that's not an indictment on the nursing home. It's just the reality of these are very busy facilities. They have the staffing they can get, and sometimes that's a big issue. And it's very hard for people to put A and B, and you've got 20 different people putting stuff in the medical record. And you got to put fact A and fact B together to decide that there's a potential issue. And that's what the strength of data mining is the ability to do that. So hopefully that answered your question.
Absolutely.
So, but in the 2 counties where you did the pilot, there were no issues of them releasing the data? And what's the?
No. So we've been able to get the data in the recent past, and just in the last few months. They're now, some of the EMR companies are putting some technical obstructions in the way of getting the data, and they really can't do that.
I understand. I look forward to learning more about your.
I'd be glad to get together.
Absolutely. Very fascinating.
Thank you.
I have Delegate Morgan.
Thank you, Madam Chair.
My pleasure.
So everything's HIPAA compliant in this. The digital records probably already exist for the patients. Is the patient being charged anymore to have that digital record?
So when Medicaid pays the nursing centers pay for that EMR data, and to have that EMR in place. And it's tremendously useful. It replaces the old medical record. But we wouldn't ever think about saying, oh, we got a new nurse seeing the patient, we're going to charge a fee for that new nurse to see that medical chart. They're paying for it already. And, you know, and so that's already in place. And the Cures Act, there's exceptions in the Cures Act, but one of them makes it very clear, we're happy to share this, that you can't charge members of the care team to use that data. And that's very clear in the Cures Act. So this is really just tightening that up.
You're welcome. Thank you for the question. Delegate Bandari
My question has been asked.
has been answered. Any other questions or concerns? Seeing none, thank you so much for being with us today.
Thank you, Madam Chair.
My pleasure. And this actually concludes the bill hearing on House Bill 786. Next, we're going to go on to House Bill 977, and that is Chairman Resnick, Maryland Department of Health, Office of the Chief Medical Examiner. Welcome, Delegate.
Thank you. If I may bring up Dr. Chen from the Department of Health.
Absolutely. You actually have whoever you want to bring, that would be great.
Okay.
Yeah.
Just us.
Okay.
I thought it was.
Right. There were a couple of people here supporting your bill, but we'll call them later.
Okay.
Okay.
I was not aware of extra witnesses, but great, more the merrier.
You got support here.
So thank you, Madam Chair, Madam Vice Chair, members of HGO. The bill before you deals with the Office of the Chief Medical Examiner. As some of you know, over the last 18-plus months, I've been very involved with the work of that office and the lack of staffing that they have experienced and the backup of work that has caused some local headlines and some national headlines. One of the issues that we are seeing within that office is when it was originally established decades ago, responsibility for that office was split. So the budget and some of the administrative management issues are handled by the Department of Health, but the hiring of the chief medical examiner, the deputy chief medical examiners, the purchase of equipment, et cetera, is actually all handled by the Postmortem Examinations Commission, which is a separate independent entity appointed by the governor. So because you have that dual management issue, we have had a disjointed management structure to be able to do things like hire a new chief medical examiner, which we currently do not have. We're still operating under a deputy at the moment, and hire additional staff and to be able to do what we need to do to appropriately and respectfully manage the remains of those who need autopsies in the state. So under this bill, we're actually going to be changing that structure to put the hiring, the procurement, and all the other functions under the Department of Health, under the Public Health Administration, and Dr. Chen is here to discuss that. And turn the Postmortem Examination Commission into an advisory commission. And they're volunteers, they're still appointed by the governor, but they will serve in an advisory function with the management and direction administration of that office being fully directed by the Department of Health. So that is the bill in summary, and I'd be happy to turn it over to Dr. Chen and obviously answer any questions the committee might have and ask for a favorable report.
Good afternoon, Dr. Chen. Great to see you.
Great to see you. Thank you so much, Madam Chair and Vice Chair, members of the committee. I also wanted to thank Delegate Resnick for his work with us over the last year on this bill and his continued strong interest and support of the Office of the Chief Medical Examiner. Again, for the record, my name is Dr. Jinlene Chan. I am the Deputy Secretary for Public Health Services with the Maryland Department of Health. And I'm here to speak in support of House Bill 977, which, as the delegate just outlined, would change the role of the current Postmortem Examiners Commission to one that is more advisory to the Maryland Department of Health and the Secretary, rather than its current role where it has appointing authorities and other authorities outlined in statute to essentially oversee and run the operations of the office itself. However, in reality, the OCME is actually functionally within the Maryland Department of Health and within Public Health Services. And so from a day-to-day perspective, it is my office that works with the staff at the OCME to actually implement operations such as budgetary functions, procurement, human resources, transactions. All of those are done through my office and very much in coordination with those respective offices within the Maryland Department of Health, such as our Office of Human Resources, our finance officer, budget, and procurement and et cetera. So really from a practical standpoint, the bill as it currently stands would essentially shift both the authority and the responsibilities over to the Maryland Department of Health, which is essentially how it currently is operating. So I would urge a favorable report, and thank you, Madam Chair, and again, members of the committee for your attention. Happy to answer any questions.
Thank you for your testimony. Are there any questions for the delegate and his panel? Seeing none, thank you so much. And the testimony you have. Thank you. Oh, there is? No, I don't see any. Actually, the testimony that I have is written and it's all favorable. Okay? Thank you so much.
Thank you.
And this will conclude the bill hearing on House Bill 977, nice and short. Thank you. Next, we have House Bill 1120, 4, Delegate Kaiser, great timing, right? And Delegate Kaiser, you're it, and you're enough for your panel. You have some support.
They stuck the chair in a little tight there. Anyway, good afternoon, Madam Chair, members of the committee. Just a really quick and easy bill. Never easy, quick bill. House Bill 1124. Thank you, Madam Chair, and esteemed members of the committee. Through some work I've done over the years looking at how people interact with government when it comes to different services and how easily people get information when they're in one government agency about other programs within that agency or other programs within the state. And then just before session, I was appointed to chair the Joint Cyber and Information Technology and Biotechnology Committee. And part of that is looking at the information technology. So my curiosity was piqued even more through the briefing that we had before session, along with briefings we've had in this committee about the services that come through. And I'm concerned about when it comes to 211, Maryland Think, the one-stop portal, and all the different pieces, looking at, and having not a work group, but having a study being done to look at, are there gaps? Are there overlaps in the system? How is it from the customer perspective? Are state residents who get these services? And then even if there aren't overlaps between some of these, how user-friendly are these? And in the past 6 weeks, a lot of people have met with me to talk about these different systems and shown me how they aren't always so easy of an interface, how other states have done some of this cheaper and more efficiently, and that when someone is logging on to sign something, that one click to the next thing is easy and so forth, and that I think we need to take a closer look at that. So that's just telling that story to make sure that that our services connect and that the residents of Maryland get what they deserve. And so that's what I've got. Thank you, Madam Chair. I urge a favorable report on House Bill 1124.
Thank you. Are there any questions for the delegate? Seeing none, thank you very much for your testimony. We do have 2 favorable with amendments, and that is actually Richard Reinhardt and Nick Cook. Will you be so kind and come up? And as soon as you sit, you can start your testimony. Thank you very much. Good afternoon.
Madam Secretary, Madam Chair, very nice meeting you. Freudian slip there.
Maybe you see something in my future that
People do say that I have this, this talent. I don't know if it's telling the future, but I'll take it. Madam Chair, Madam Vice Chair, members of the HGO Committee, my name is Richard Reinhardt for the record. I represent Percy Public Affairs. With me today is the Vice President of System Automation, Nick Cook. We want to say thank you to the sponsor, Delegate Kaiser, for bringing this bill forward. We certainly favor this bill for its passage. System Automation is a local IT company that's been operating in Howard County since 1968. They are a national leader in regulation management solutions, and they've served over 500 agencies and have provided nearly 20 million professional licenses across the country. System Automation is also have had a long-standing history and partnership with the state of Maryland. They are currently a vendor with the Department of Labor, Maryland State Police, and the Maryland Department of Health, specifically with professional boards and commissions. Please let this record reflect that we believe that the one-stop portal is a laudable concept. It has the potential for achieving a singular platform that is both modern and user-friendly. However, in its current incarnation, it does not serve either. As a matter of fact, it falls short of creating that one streamlined service for our users. And Nick will provide a little bit more of that overview in a moment. For over the last 3 years, we've made every effort to bring the attention of our concerns to the state. However, they've been ignored. Had it not been for the attention by the House Subcommittee on Health and Social Services, we were wondering if our concerns were ever going to be addressed. We encourage this committee to look at our written testimony that we submitted to the budget committees And we also encourage you to look at our letter that we submitted back on January 31st to the Joint Committee on Cyber IT and Biotech. This bill will finally force the General Assembly and the agencies to answer the questions we've been asking for the last 3 years. We strongly encourage your support, and we urge a favorable report. Thank you.
Thank you for your testimony and for respecting the time. We appreciate it. Next, please.
You're welcome.
Madam Chair, members of the committee, thank you for the opportunity to speak to you today about this important bill. As Rich noted, my name is Nick Cook, and I'm a Vice President with System Automation, headquartered in Maryland and have been since our founding in 1968. The goal for my 2 minutes with you today is I want to familiarize those of you who may not already be familiar with the one-stop experience. And to do that, we've included in your folders a slide deck that contains a few screenshots that guide the experience for, in this case, a therapist looking for and applying for her license online. Beginning on slide 4 and ending on slide 8, you'll see all of that annotated for you. I don't have enough time to go through each, but I'll just summarize it as such. You're brought to a page where you're prompted to search for the license for which you want to apply. You're then brought to another website that tells you the board that regulates that license and approximation of the fee, and a corresponding link to apply online, which ostensibly would bring you to an online application. Then you're brought to the next page, which is an entirely different page altogether that contains a list of a bunch of PDF documents, and the therapist in this case, who's trying to obtain a license to provide needed mental health care in the state, has to discern which of these PDF documents am I supposed to fill out, and then print, and then mail to the board. To say that this online experience is inelegant would be charitable. It's certainly fair to say in our estimation that the value that the One Stop has delivered thus far is not commensurate with the amount of taxpayer expense it's incurred. The challenges to realize this vision, as Rich said, are laudable, but the challenges are vast. And overcoming those challenges starts first with collaboration, finding opportunities to integrate with the agencies that already exist, have IT systems that already exist, and importantly, not forcing a one-size-fits-all approach onto them. This is how one of our customers in Indiana did this and delivered far greater value with their one-stop that they called InBiz at a literal fraction of the taxpayer expense that we've incurred to date. Tens of millions of dollars have already been spent, with many millions more to come. We've included on slide 9 our proposed amendments to the bill that we believe would serve the committee and your constituents well prior to authorization of any additional funding. Thank you.
Thank you very much. Appreciate it. Are there any questions for these two witnesses? Vice Chair Collison, don't worry, I see you were coming.
Okay, there we go. Thank you, Madam
Go
Chair.
ahead.
So, Mr. Cook, and it's nice to see you, Rich.
Nice to see you too, Madam Chair.
So you are a business who offers this sort of integrated service, and are we envisioning some sort of procurement process to, identify businesses, or are you currently in the systems and asking to be making the one-stop function more usable?
We have a customer footprint across the country in nearly 24 states, including here in Maryland, providing licensing software to agencies like MDH and many other departments that do licensing across the country. And through that experience, we've also integrated with other one-stops that were born out of other agencies unrelated to our business, where we worked closely with the Secretary of State's office in Indiana, for example, to truly integrate and create a truly seamless experience for the citizens of the state. And that's what we want our home state to do. We want to be able to have that same experience at the same level of taxpayer burden that we've seen other states do successfully, that thus far we don't feel our home state has done.
Sure. Do you currently have a contract with the state?
We do, yes, ma'am. So there are about 4 or 5 different agencies within the state that we currently do business with.
Okay, great. Thank you very much.
Sure.
Any other questions? Yes, Delegate Woods.
Thank you so much, Madam Chair.
My pleasure.
Just a quick question. Do you have any specific efforts that point to small minority or women-owned businesses in terms of making sure contracts are procured to them, particularly because of the disparity in services to those minority populations?
So we function as a vendor, so we're responding to the procurements that often do have those requirements in place, and we do have partnerships with small disadvantaged businesses, woman-owned businesses, minority-owned businesses, and partner with them and are happy to continue partnering with them on initiatives like this and other initiatives as well. Services that would be available to assist the businesses. I'm not sure I'm understanding the question completely. Forgive me. So is the question, do we hold a contract that could be used to pass through to a small disadvantage? Okay, yes. So yeah, we have multiple statewide contracts that we're on here in the state of Maryland, CATS Plus being one of them, COTS being another, and other non-statewide vehicle contracts. None of them have those requirements within them, but we certainly have the ability to bring those resources to bear on those contracts that already exist. Does that answer your question, ma'am? Thank you.
Thank you. Thank you. Thank you for your patience, and thank you for the question. I don't see any other questions for you. Thank you so much for being with us.
Thank you very much.
Thank
Madam
you.
Chair.
Our pleasure. I do have a oral witness, virtual witness. I understand that person is not here, and the name is Tiffany Turner Allen. Now, do you see her? No? Okay. All right. And this actually concludes the bill hearing on House Bill 1124. Next, we have House Bill 1199. Delegate Howard, who has been very patient and waited for like 3-4 hearings to go through, and health insurance, Lyme disease, and related tick-borne illnesses, long-term antibiotic treatment. Thank you for your patience, okay?
Happy to wait. This is an important bill. For the record, Delegate Howard, I'm pleased to present HB 1199. Good afternoon, Madam Chair, Madam Vice Chair, colleagues. Essentially, this bill before you deals with long-term Lyme's disease treatment and antibiotics. I found it interesting, and one of the gentlemen in one of the earlier panels talked, and not to be too forward, said it's about the dollars. I'd like to draw the committee's attention to the fiscal note, and I think his comments were exactly spot on. The difference is that we don't know if it's about the dollars. According to the fiscal note, there would be some impact to local municipalities and ratepayers through carriers if we were to implement long-term Lyme's treatment, antibiotic treatment. But the fact of the matter is that we aren't sure. And then I would also like to draw the committee's attention to the, I believe it's called the Life and Health Group Insurers of Maryland's testimony. I believe it's page 2, paragraph 1, the last line. It talks a little bit about a study or work group. If that's the committee's will, I'd like, and it's appropriate, I'd like to volunteer to serve on that. This is an important issue. I think it's time we get to the bottom of whether or not it would grossly and adversely affect a ratepayer. But also, too, I want everybody to keep in mind that right now, as of 2020, the CDC's numbers, we have 31,400 and I think 23 or 32 Marylanders who are negatively impacted by Lyme's disease. So with that, I am not a subject matter expert. I did have a member of a panel of a woman who comes up and is ardent and fights for this bill every year. Unfortunately, she is sick, and quite frankly, due to ongoing Lyme's. So although I'm not a subject matter expert, I would love to entertain any questions. And if I can't get you the answer, I certainly will circle back and be happy to answer any questions that you may have. Also, there was a video that was sent to you today. I would ask that the committee go back and watch that. It's very compelling testimony by another fantastic attorney who is negatively affected by Lyme's disease as well.
Thank you. Thank you for your testimony. Are there any questions for this witness? Seeing none, and actually there is Delegate Shalega. Go ahead.
Thank you, Madam Chair.
My pleasure.
Thanks for bringing this bill.
Thank you.
So it seems as though the opposition to this bill is that they don't feel like long-term antibiotic regimen is helpful in Lyme, yet the video that you sent, I watched, clearly there's beyond one single anecdotal evidence that not appropriate for everybody, but appropriate for some. What would you say to answer that opposition from the Health Department and the?
Absolutely, and thank you for the question, Delegate. I'm just reading up on this now, and not really just reading it, but I'm really just refreshing myself. I've had this bill several times before, although fortunately I've never had Lyme's disease. I would just say that this would be under the care and direction of a physician. So this would be a patient-physician decision. The criteria for this long-term antibiotic is laid out under the fiscal note of the bill. There's 6 or 8 different criteria in which the physician would be able to administer long-term care, and it would be under the supervision of a physician. And it's my understanding too that sometimes, quite frankly, these things crop up. According to CDC white papers that I've read, this disease has the ability to sort of camouflage itself almost, in that it will go to an uninfected area of the body. There's other variables as far as cell transmutation, hiding within cells, other co-infectious sort of diseases that come along with Lyme's. And there's, quite frankly, I'm surprised that there's a lot that we're still learning. But as far as long-term care, that would be, again, that would be under the supervision of a physician and the patient. Yep.
Delegate Woods.
Thank you, Madam Chair. Just, I did see the video also, and I had a question and hope maybe you can help me. I did not understand the testimony of the attorney that for children, it seems to be much easier to get long-term antibiotic care. Can you tell me what is the disconnect? Why is that not the same opportunity for adults?
Great question, Delegate. I don't have that information for you. I will get that and get back to you with that. I'm not sure of the disconnect. My sense is it's because it's children, but that's a very broad and uneducated guess on my part. I don't want to do that. It's an important issue, so I will get you a definitive answer. Absolutely.
Delegate Lewis.
Thank you, Madam Chair. Thank you, Delegate, for bringing the bill. And I really do, I can feel your care and concern for people suffering this chronic disease that we are still learning about. And I'm just wondering, since you've worked on this for a long time, you've been trying so hard, I wonder if there's another approach that might be fruitful so that folks can get the help they need and you can help move some good policy, maybe the establishment of a work group, study group, commission, or join forces with other infectious disease associations, join forces in that way. Have you considered other tactics for moving this idea forward?
I was quite frankly, of course we all want to see our bills pass, right? But don't fall in love with them, exactly right. But I was very encouraged, quite frankly, to see that the opposition did mention a work group, a study, so that we could get those data points as far as cost is concerned, especially as cost is concerned. Maybe hash out some other data points as far as what long-term prescriptions should look like and how they should be administered. We don't have that information right now. And that, again, I would be the first to volunteer and spend my summer or whatever it is, whatever is the will of the committee, to serve on any type of work group or task force. Yes, ma'am. Absolutely.
Okay. I have Delegate Bagnall. Your question was answered. I don't see any other, actually, yes, Delegate Gazzoni.
Thank you. Just a quick question. I'm just curious about what long-term kind of means. I actually have a friend who was on, I believe had a port and was on intravenous antibiotics for Lyme's for, I think, about a year. So I'm just curious, is that what qualifies as long-term, or is this something past that?
I believe it's, let me look in here real quick. Well, it's my understanding that it's something past that. I think there's some initial antibiotics and topicals that they can issue, or not issue, I was in the military, that term comes very easy to me, that they administer, but anything past CDC recommended time frames would be considered long-term and ergo not covered under insurance. Absolutely.
Okay, thank you. So I don't see any other questions. However, I did read the letter from the league and the letter from the health department. The letter from the league, it's actually relating to a mandate, the fact that it's a mandate. The letter from the health department is actually in opposition because they do not, they state that the CDC does not recommend it. I know you have had this bill many times. So in the interest of moving us along, because, you know, there is an opposition, right? And it's tough to pass a bill when the Department of Health is opposing it. I think what I would like to do is, if you and I can talk offline.
I would love that.
And see what we could do without a bill, but get them to sit down with you and have a conversation and maybe put together an informal group.
That would be
Will you be
wonderful.
open to that?
That would be wonderful, Madam
Okay.
Chair. Thank you so.
We will do that. If
Thank you
could-
so much.
My pleasure. Just follow up with my office, okay?
I will immediately. Thank you.
You're
Thank
welcome.
you, colleagues.
And thank you for your patience today.
Absolutely. Thank you, colleagues.
My pleasure. This actually concludes the bill hearing on House Bill 1199, and we're now on to House Bill 1217, and that is Maryland Medical Assistance Program and health insurance require coverage for biomarker testing. Will you please come up? And that is actually Delegate Tolles. Is she here? She's not. Okay. May I ask you for, and Delegate Fennell is not here either, and they both are next. May I ask you for a huge favor, and I'll make it up by giving you an extra minute. Can you go back and sit, and let me just call another bill while we call the delegate, okay? And I'll give you an extra minute. All right, Delegate Bandari, you are on, because you're here. And will you be so kind and call those two delegates? You did Sherry? Okay, and Delegate Fennell as well, Tolles and Fennell. Thank you. Delegate Bandari? And Delegate Bandari, you do have a panel. May I ask Aliyah Horton to come up, Christine Lee, and Sarah Price, and will you be so kind and sit with the delegate? And Delegate, you may get started. Thank you, and thank you for your flexibility, okay? Good afternoon.
Good afternoon. Chair Benia Melnick, Vice Chair Bonnie Collison, and members of wonderful Health and Government Operations Committee. I'm here presenting House Bill 1151. I would like to call this the parity bill, which proposes to require the Maryland Medical Assistant Program, Maryland Children Health Program, and certain insurer, nonprofit health service plans, and health maintenance organizations to provide coverage for all services rendered by a licensed pharmacist within the pharmacist's lawful scope of practice to the same extent as services rendered by any other health care practitioner. Last year, this great committee passed House Bill 1219 as a study bill, which is this bill is the outcome of that bill. And thank you, Vice Chair Bonnie Collison, for doing the heavy lifting on that bill. And Aliyah Horton, who is expert of the bill, will elaborate on this later on. Currently, pharmacists are often limited to providing certain services, despite being trained and qualified to offer a wide range of healthcare services. This restriction not only limits patients' access to healthcare, but also burdens other healthcare practitioners unnecessarily. Expanding pharmacy services will give patients more accessible, convenient, and cost-effective healthcare services. The proposed bill will also ensure that the reimbursement for services provided by pharmacists is not dependent on whether they are employed by a physician, pharmacy, or facility, or acting under a physician's order. This is a significant step towards recognizing the role of pharmacists as independent healthcare providers. In conclusion, I urge to support House Bill 1151. And for the committee's information, today the cross-file of this bill passed second reading from the Senate. And I have Aliyah Horton.
Good afternoon, Aliyah Horton, the Maryland Pharmacists Association. I thought we were going to be last and we could close out this hearing with a kumbaya moment. We are MPHA and the Maryland Pharmacy Coalition is obviously in favor of this bill. I'm very pleased to say that we're bringing a pharmacy-related bill that has the support of MedChi, the nurses, as well as the insurers. And I think that they recognize the healthcare benefits and the return on investment that this bill will make. Delegate Badari also already mentioned that this is the outgrowth of the outcome of the MIA work group. And as you know, last week we talked a lot about pharmacy benefit managers, and last night in subcommittee we talked a long time about pharmacy benefit managers. And I will just say that this gives an opportunity to pharmacists to be reimbursed for their clinical services beyond the dispensing piece, where that is largely outside of the scope of PBM, so they can really provide additional services. This is not a scope of practice bill. However, when scope of practice bills are brought before this committee, we've often had to fight a separate battle about getting reimbursed for the advanced services. And so this would eliminate that part. Last year, the General Assembly passed provide a prescriptive authority for pharmacists to prescribe nicotine replacement therapy. As of right now, pharmacists, if they're engaging in that counseling, providing the prescriptions, doing the follow-up, and working on a tobacco cessation program with a patient, they're not getting reimbursed for any of those services. So this would allow that to be covered, and for pharmacies and other practice settings to really expand the use of pharmacists. And so with that, I will end my testimony and urge a favorable report. Christine Lee Wilson is a past president of MPHA, and she can talk about the impact on her practice. Thank you.
Good afternoon. My name is Christine Lee Wilson. I own Professional Pharmacy in Rosedale, Maryland. I have been practicing at the top of my licensure since 2005 when I graduated. For those who have been sitting on this committee for years, you know I've come and testified, and we started with birth control, and then we did long-acting injectables, and each year we come out and we ask to get reimbursed for another service, and that process just starts here, and the bill gets passed, and then we have to go to the regs, and then we have to go to the boards, and then the pharmacy has to figure out the process, and the insurance company has to figure out the process, and it's a super inefficient system to go topic by topic and request reimbursement for each of those services. So this bill would allow us to just say, anything under the scope of practice, the pharmacists can get reimbursed for, and it would be a much more efficient process to try and figure out these protocols and processes to get paid. And so I ask for a favorable report, and I also just want to reiterate Aaliyah's piece on reimbursement issues. I'm sure everybody on the committee is well aware of the challenges of reimbursement issues. Yesterday, I heard of another pharmacy that just closed in the area. And it really does just break my heart that we have more independent pharmacies closing, they just cannot survive in the current marketplace and the chaos that's out there. So it's not going to fix everything, but it certainly would help. And so with that, I could answer any questions. Thank you.
Thank you very much. Is Sarah Price here? Sarah Price? Okay, I don't see her. Are there questions for this panel? Delegate Szeliga.
Thanks, Madam Chair. This is for Christine. It's nice to see you, but are you telling us you don't want to come every year to see us and take a day off of work? Thank you.
I'm sure we'll have something to come for.
Delegate Johnson and then Delegate Kerr.
Thank you, Madam Chair, and thank you, panel, for bringing us the information. Aaliyah, can you tell us a little bit about the proposed amendment on this bill?
Sure. So we did submit the report from MIA to bill writers for this bill, but MIA did come and say they'd like to have a little bit of a technical change to the language on the last page to make it better aligned with current insurance statutes. The other amendment was from the League of Life and Health Insurers, which would extend the effective date, and the date that was passed on the Senate side was January 2024, and we are fine with both of those amendments.
All right, thank you. Thank you, Madam Chair.
Okay. Any? Oh, Delegate Kerr.
Thank you, Madam Chair. Aaliyah, you mentioned that MedChi was in favor and that I guess I just want to understand, I think what I picked up from you is that there are benefits to healthcare practitioners outside the pharmacy.
Yes, there are benefits for just broader health outcomes for patients. And we have pharmacists that are employed in lots of different locations and practice settings. We have pharmacists that are in federally qualified health centers where their work is not, there's not a mechanism to reimburse them. There are pharmacists that may work part-time and have other agreements with physicians and are embedded in physician practices. And their pay is coming from whatever the physician gets reimbursed for. So this would allow the coverage of their work. And I think it would greatly improve the opportunities for pharmacists to work in many different practice settings where it can be affordable. We also have clinics where more practices would like to hire pharmacists because that collaboration is really helpful for the patients in medication adherence, reducing hospital, returning to hospitals for emergency care and that sort of thing. And so it creates a better opportunity and support for that pharmacist's work. Thank you.
Okay. Seeing no further questions, I guess I would just like one sort of example of and I think you mentioned a few, but just to put a fine point on it, of the kinds of what you're calling clinical activities that this bill addresses.
I'm going to turn it over to Christine because she does about everything.
Okay.
Sure. So a good example would be this past November, I started patient remote monitoring. So I have referrals from a physicians group for patients who have high blood pressure. They send me the referral. I am the one that is monitoring their blood pressure. I am the one that's making the decisions with the blood pressure. In order for me to get paid for that service, I have to go into their electronic medical record, bill for that service. They have to then get the check and then submit it back to me. So the only thing they're doing is acting as the funds for payment on that service. They're giving me authority to do everything else. So that would be an example of a collaboration with a provider. And the other piece right now, which is great, is, a good example is the injectables, which we were given authority to do. However, it's still, that process has not been ironed out, and I have not been successfully paid because we're still trying to figure out the workflow and get recognized as a provider with the state. And that's been a challenge. So to have to do that over and over and over again for each different clinical service has just been difficult.
Okay. Thank you very much. Thank you, Delegate Bandari, for working hard on this bill.
Thank you.
And Aaliyah and Christine as well. And we'll take a kumbaya moment at any time. So I would like to call.
Thank you.
Thank you very much. And I'd like to call Matt Celentano. Favorable with amendment.
Good afternoon, Madam Chair, members of HGO. My name is Matt Celentano, here today on behalf of the League of Life and Health Insurers of Maryland, here in support of House Bill 1151. Ms. Horton alluded earlier to our request for a delayed effective date of January 1, 2024. That's just because our systems don't currently contemplate the changes that will take effect with this bill, including we need to develop credentialing, reimbursement, and networking. But we thank the chair for participating in the work group this summer. We thank the MIA for leading the way. We thank Delegate Bandari for bringing this bill, and thank you very much.
Okay, no questions for Mr. Celentano? Oh, we're so unused to the.
I'll be back 2 more times.
Thank you very much, Matt. That concludes the hearing on House Bill 1151. Oh, I'm sorry. That is not correct. I have Deborah Mercado. Unfavorable. Deborah Mercado? Okay. Oh.
Madam Chair, is there a price on the list?
Yes, I did call you. You didn't hear me? Oh, well, since you're here, let's go ahead. And while you're sitting down, is Deborah Mercado in the room? Okay, not seeing you. Go ahead, Ms. Bryce.
Thank you so much. My apologies, committee. I was testifying in Environment and Transportation. My name is Sarah Price. I'm here on behalf of the Maryland Association of Chain Drug Stores in strong support of this proposal. We've shared with the committee before that 90% of Americans live within 5 miles of a pharmacy and that people know and trust their community pharmacists. This body has taken steps to authorize pharmacists to provide certain services like prescribing birth control without a doctor being involved in order to expand access to health care for Marylanders. The issue that pharmacies then face is that the pharmacists are authorized to provide the services but are not always paid for the consultation involved with performing them. Some of our members have reported that they have struggled to operationalize providing birth control because they're not being reimbursed for the counseling that's involved in getting the prescription set up. Requiring that pharmacists be paid for the services that they're providing, just like any other healthcare provider, would make a very big difference to pharmacies being able to meet their operational costs and provide effective healthcare to their communities. Oftentimes, retail pharmacies are able, the pharmacy operations are able to be subsidized by the retail costs, transactions that occur in the rest of the store, but that is not the case for many independents. And ultimately, we just want the pharmacy aspect to be able to be made whole for what they're providing so that then the pharmacy itself can afford to bring in enough labor to meet the demands for their community. And we think this would have a positive effect on the pharmacy and the community that it is in. So we would urge a favorable report. Thank you.
Thank you. Are there any questions for this witness? Seeing none, thank you very much for rushing back.
Thank you.
And that does conclude the hearing on HB 1151. And we're going to go to HB 1217, and I believe that's Delegate Tolles. Delegate Tolles, if you'd come on up, welcome to HGO. And if you have a panel, please ask them to come up.
We have, let's see, might need to put some extra chairs. Sit down. And Madam Chair, we have 2 virtual that are on the sponsor panel as well.
Okay, they'll be getting those set up as we begin. So Delegate, I'll let you start.
I can start? Okay. Okay. Is Ann, we just want to switch out with Ann? Okay. Good afternoon, Madam Vice Chair Cullison and members of the Health and Government Operations Committee. I am Delegate Karen Tolles. I am now the lead sponsor for HB 1217. I want to publicly thank now Senator Kelly for her work on this bill. I am also the second vice chair of the Legislative Black Caucus of Maryland and the chair of the Health Committee. This is a priority for the caucus, and the reasons you will hear in my testimony. House Bill 1217 requires the Maryland Medical Assistance Program and private insurance carriers to provide coverage for biomarker testing that is supported by medical and scientific evidence. It also establishes the utilization review for biomarker testing to create a standard for assessing this technology that improves treatment outcomes and saves money in the healthcare system. HB 1217 is an important piece of legislation that is critical for ensuring that detection of cancers and other diseases can be found more expeditiously, particularly in Black women and men. Despite evidence demonstrating the effectiveness of biomarker testing and targeted therapy, not all individuals currently benefit equitably from these advances. There are notable racial, ethnic, and socioeconomic disparities in access and utilization of these advancements in care. These disparities in access and use of medically necessary biomarkers, testing and targeted therapy can potentially widen existing disparities in patient survival. The National Black Caucus of State Legislators adopted resolutions recognizing the importance of biomarker testing in advancing health equity and reducing disparities. You'll notice sitting here with me At the table is Ms. Kimberly Robinson from Cigna. Ms. Robinson and other carriers met with us, negotiating in good faith, and I am so pleased to tell you that we've all agreed to a few amendments that make this bill technically sufficient and meaningful to the people of Maryland. Madam Chair, I want you to know that we did the work before the hearing to come before you with the amendments. We all agree, and I have requested the amendments. The amendments we agreed to with the carriers do three things. One adds a definition and makes a clarifying amendment regarding the allowed purpose of a biomarker test. The second eliminates one of the 6 criteria listed in the bill regarding the test to be covered. And the third eliminates the creation of a separate prior authorization standard. In addition to these compromise amendments, the Black Caucus is requesting 2 additional amendments. One directs the Office of Minority Health, the Health Disparities to convene a work group to develop an outreach plan to educate communities negatively impacted by health disparities about biomarkers and biomarker testing. And it also directs the Maryland Healthcare Commission to report on the impact of providing access to biomarker testing to individuals based on race, gender, age, and public or private insurance. I also want to thank MHGC for working collaboratively with me and the Black Caucus and other stakeholders. However, I would like to express my extreme disappointment with the letter submitted by the Health Department with some of with the fiscal note. And it is, an issue with that note because private insurance carriers see the value of medically necessary biomarker testing, see that it saves money and helps improve the health outcomes. There is no acknowledgement by the Health Department of the cost saving, not to mention the impact on people's health and lives when someone gets more appropriate treatment for their condition. So it does not mention that. However, it is fair that you and I can have the best. It's not fair that we can have the best that science has to offer, but people living in poverty cannot. I would love the department. I hope the department is watching, and we will be able to hear some of the testimony today. 4 states have already enacted this law: Arizona, Illinois, Louisiana, and Rhode Island. If we are serious about saving lives, especially Black lives, they matter, and they will be impacted on a positive note with these biomarkers to treat cancers and other diseases more than any other race. I respectfully ask that my colleagues here pass this bill out of this committee favorably. Thank you, Madam Chair.
Thank you, Delegate Tolles. Wow, you've done a great job of picking up from former Delegate Kelly, and I appreciate all the work of the committee. Appreciates all the work you've put into this.
Thank you for your kind words, Madam Chair.
Thank you. So is Devon Adams here? Devon, you want to go next?
Thank you, Madam Chair and members of the committee for the opportunity to testify in support of House Bill 1217. My name is Devon Adams, and I'm a senior analyst at the American Cancer Society Cancer Action Network. This year, it is estimated that over 35,000 Marylanders will hear the words, "You have cancer." Fortunately, there have been advancements in improving cancer outcomes with the use of precision medicine. Biomarker testing is key to unlocking precision medicine and all of its benefits, and is increasingly important for the care of cancer and for the treatment of other diseases such as arthritis and other autoimmune conditions. As you previously heard, despite the evidence showing the remarkable benefit of biomarker testing in precision medicine, not all communities are benefiting equally, and this would include older adults, Black individuals, those who are treated in community settings, rural residents, and those who are insured by Medicaid. These disparities in access and the use of biomarker testing can potentially widen already existing disparities in cancer outcomes. Therefore, improving access to biomarker testing is important for advancing health equity, and we must dismantle these access barriers, including current barriers around insurance coverage. Evidence has shown that there is unequal access to biomarker testing in Maryland, with many residents and plans that are currently more restrictive than what is recommended by clinical guidelines. In other words, there are very real coverage gaps. Additionally, a recent survey of over 300 oncology providers, 66% reported that insurance coverage for biomarker testing was a significant or moderate barrier to appropriate testing. It's important to underscore that biomarker testing is not indicated or appropriate for all cancer patients. We're not advocating for coverage for every existing biomarker test. Rather, this legislation is tied to rigorous sources of medical and scientific evidence, such as clinical practice guidelines that guide who should receive this testing. Improving access to biomarker testing that leads to increased access to targeted therapy can benefit all communities. We encourage you to support House Bill 1217 to make it possible for more patients to get the right treatment at the right time. Thank you.
Thank you. Sydney Barnes? You want to trade places?
Hi, good afternoon, Madam Chair, delegates. Thank you for the opportunity to speak. My name is Dr. Sydney Barnett. I am an internal medicine hospitalist at Anne Arundel Medical Center. 6 years ago, while I was in my medical internship, I started wheezing, and having a strong family history of asthma and having some lingering symptoms from a prior pneumonia, I decided to be seen by a pulmonologist. After initial tests showed a lung abnormality, I was sent for a whirlwind of tests that resulted in a diagnosis of stage 4 lung cancer. At the time, I was 33, former ballet dancer, 5K runner, and a never smoker. During that time, I questioned a lot of decisions that I made in life. Majority of my life I had spent in school, trying to attain a dream that at that point in time, I wasn't even sure I was going to be able to live to see. Thankfully, my oncologist sent me for biomarker testing, and I was approved for it. She told me that I had an ALK mutation that was driving my cancer, and at that time, I was ignorant to the significance of what that meant. So what it meant was I would not have to do chemotherapy. I would not have to deal with debilitating side effects of treatment. I would be able to complete my intern year, my chief residency year, and my residency on time with my cohort. It meant that I would be able to work as a hospitalist and help people like I wanted to, with insignificant side effects of treatment. It also meant that 6 months ago, when I was told that it spread to my brain, that we knew that we could switch it to a new medication that would target the cancer. I would not be able to be in front of you like I am today if it wasn't for biomarker testing, and that's why I'm in favor of this bill. Thank you for your time.
Thank you. Thank you for sharing that story. Masha Mohabtash?
Yes, thank you, Chair and the committee, for having me and allowing me to testify on this bill. I'm a medical oncologist working for MedStar. I'm the director of a cancer center for all Maryland sites for MedStar, overseeing 8 hospitals and infusion centers. Rarely I see a patient with cancer for whom I do not order a biomarker. And especially for, as we just mentioned, lung cancer, breast cancer, prostate cancer, which are the most common cancers, and number 1 killer, lung cancer. And unfortunately, many times and oftentimes, my patients' treatments are delayed for several weeks to several months because we cannot get approval for biomarker testing. It has been tremendous change in the patient's life expectancy, quality of life, and response to treatment. For everyone, especially elderly people who are not candidates for cytotoxic chemotherapy causing lots of side effects. These treatments, as you can see, have minimal side effects. People can maintain their quality of life, prolong their life, increase survival at no cost of their quality. So I'm asking you to pass this bill to allow all the patients benefit, regardless of the type of insurance they have, to be able for their physicians and oncologists to tailor their treatment to the best options. We can have precision medicine, but not without biomarker testing. If we cannot do that, we will be much behind science and cutting-edge science. Unfortunately, insurers are far behind that. Thank you for having me.
Thank you very much for coming. Kim Robinson.
Good afternoon, Madam Chair, members of the committee. Kimberly Robinson here for Cigna. I'd like to say thank you to Delegate Tolles and to Ms. Seacott and the other proponents of the bill for their collaboration, as we did offer amendments that have been accepted and are coming to you as consensus amendments today. You heard the delegate describe the 3 amendments. With the 3 amendments, we believe the bill is the right step for the state of Maryland to take to move forward on this issue. We do support and we do cover biomarker testing today. We believe very strongly in trying to help get the right procedure to the right patient and in working to adopt coverage for new technologies that have been, and new tests and other treatments that have been backed by strong science that has been peer-reviewed, that is evidence-based, that is clinically valid, and that is able to produce results, because ultimately what we want to do is to help people be well. And so we believe with the 3 amendments to the bill that this will be a step forward for the state of Maryland in this space. And with that, we are happy to urge your favorable report.
Thank you. Nice to have you at that table. I'm going to take a little privilege. There are a few more folks on the sponsors panel, but I'm going to let us ask questions of this group first, and then I'll call the remainder of the sponsor panel up to the table. Are there questions for this panel? Delegate Martinez.
Thank you, Madam Vice Chair, and thank you, Delegate Tolles, for championing this bill. This is extremely important. Just because of my ignorance, could you guys or someone on the panel let the committee know what the cost would be to uninsured or underinsured folks currently right now if they wanted to get this type of testing?
So it depends on what biomarker is being tested. Some of them are individually billed. Some of them are come in a group of testing, like going over several hundreds of genes to be tested. I cannot give an exact number because there are so many different tests. Some of them are bundled together. Some of them are, individualized. I do not know if anybody else knows about the cost.
Ms. Seacott's going to add to that as well, Delegate.
Okay, great. Not yet. When she comes up, we'll ask her, right? We'll remind her. I do have a question. I think this is for you, Kim. One of the concerns that the Department of Health has named as, or has identified, is that while they say that they are currently covering biomarker testing for cancer, but they're concerned that these biomarker testing will be applied to other kinds of conditions. Are commercial carriers currently covering the biomarker testing for other kinds of conditions or only cancer now?
I can't say with certainty if we're covering other than cancer. If we are not covering tests other than cancer, it will be based on what the medical clinical literature is dictating what's been most effective. So there are standards that are included in this bill. And so what I would say is, we were comfortable with these standards because we think they set the right guidance for when we are to adopt tests for new markers. I know cancer was certainly an out front area where biomarker testing was happening, and that every cancer, or every kind of cancer and every disease doesn't necessarily have one that's been well identified and has an associated treatment. Because it's one thing to know you have it, it's another thing to have a treatment that goes along with being able to treat the underlying disease. So I can't answer that specific question for the department, but what I will say is that under the bill, we do see this as a door to make sure that other biomarkers that have clinical validity are being added into what's being covered, at least on the commercial side.
And those standards give you the right guidance to move
We believe
forward.
so.
Okay.
And we worked with the proponents, and we made some compromises about what's in the bill, and we're comfortable with the standards that they're set.
Excellent, thank you. Any other questions? Seeing none, I'm going to call up the second half of the sponsors panel.
Okay.
So Ann Seacott, Michael Patty.
Do you want me to stay?
You can step back if you'd like.
Okay. Thank
Would
you.
like you to stay for the rest of the hearing,
Of
though.
course, of course.
And virtually, Has Renee Mefra? No, okay. So you want to bring up Melissa Horn? And as long as we're doing favorables, I'm also going to call Delora and Matt back up to the table. Yeah.
And Madam Chair, Michael Patty, it was going to be me or Michael, so you can cross Michael off the list.
I missed the or, okay.
That's
Thank you, go ahead, Ann.
Thank you, Madam Chair. Ann Seacott here on behalf of the American Cancer Society Cancer Action Network. And I was mostly going to be here in case there were questions about the amendments, but I'm happy to address issues around some of the cost and some of what the Health Department wrote. There was a Milliman report that we can provide to you all that talked about, did an analysis of the impact of the cost of biomarker testing and the benefits to it in both the commercial and Medicaid markets. And their report actually says for a single test that the average market price in Medicaid is about $79. I think what the doctor spoke to was sometimes the tests have a larger panel and they can be more expensive. But it doesn't have to be overly expensive, depending on what is being tested. I do want people to realize this, just as Ms. Robinson had talked about, this is when these tests are medically necessary. This isn't everybody says, oh, I want to get a test for this or that. This is only when it's medically necessary, when there's a treatment available for a particular test, that a test can help direct patients to. And that's part of why I think we were all rather stunned at the letter from the Health Department. The Health Department has said that they are going to be moving forward with covering some biomarker testing for, we don't know the exact nature of the limitations, but within some limitations. So we don't know if what they are already have in the works that they are about to implement, how much that covers, how much money they think that's going to cost, and therefore what the difference is between what they think, what they put in the letter and what they actually are planning on planning on doing. I will say that I don't know that they've seen the amendments, and I don't know how much that may impact. So we are very much looking forward to working with the department to see if we can't get something that we think is a much more realistic fiscal note for the coverage.
Thank you. Delora?
Good afternoon, Madam Chair. So I actually was signing up a patient advocate named Karen Ziegler, and it should be under her name for testimony as opposed to my name. It may have been user error, but she's here and she's prepared to testify.
Okay, we'll switch her out for you.
Excellent.
Because
You
her
see her
name
there?
is
Okay.
here, but
Yes.
it's as a, it's.
It
the
has both of
organization.
our names on the sign
Right,
up, so
right,
we see
okay.
what the mix-up was.
Right.
One moment.
Okay.
Thank you very much.
Madam Chair, members of the committee, I'm Matt Celentano, once again on behalf of the League of Life and Health Insurers in support of House Bill 1217 with the amendments. Me too.
Thank you. Excellent testimony. Okay, Ms., is it Zanika?
Yes, hi.
Hi.
Madam Chair, delegates, thank you for the opportunity to tell my story and ask for your support for the legislation to expand patient access to biomarker testing in Maryland. I tell you without exaggeration that my access to this testing is the reason I'm here to testify today. At the start of 2020, I was 50. 20 years as a business owner, 25 wedding anniversaries past that milestone, and mom to 3 school-age kids. Despite the pandemic sense of surreal, we would never have imagined that by the end of the year I would be in the hands of a very talented surgeon at Hopkins who used robotic Da Vinci tools to remove the entire upper left lobe of my lung. I was asymptomatic, and this was an incidental find from a torn rotator cuff. I have no known risk factors, but I had stage 3A lung cancer. Every year, lung cancer kills as many people as the next 3 deadliest cancers combined. On the world stage, that's 5, and up to 25% of them are non-smokers like me. I'm improving the survival odds because biomarker testing revealed an EGFR positive genetic mutation, one with a very effective targeted treatment. We don't know the cause, but we do know that epidermal growth factor receptors get stuck in the on position. Cells grow out of control. This precision medicine plugs in and shuts them down. Even after diagnosis, biomarker testing continues to reveal common mutation pathways that these sneaky cancers use to evade treatment, resulting in next generation treatments. The one I take is on its third, and it's already in fourth and fifth, I understand. Medicine is literally working one step ahead of the disease, and insurance coverage must keep pace. Now more than 2 years cancer-free, I ask you to give the same chance to every constituent whose Maryland family member is struck by cancer. Pass the legislation to grant them equal access to life-saving biomarker testing. Swift access. Cancer cells do not stop spreading while we all wait for insurance pre-authorizations. Your action matters, and I appreciate your time. Thank you.
Thank you for sharing that personal story. We have on the screen Melissa Horn, and you're unmuted, so you may go ahead.
All right, thank you to the chair as well as members of the committee for your time today to testify in support of this really critical legislation. So I'm the state legislative director for the Arthritis Foundation, but I'm also a Maryland resident for the last 4 years and a 3-time cancer survivor. So I've been a cancer survivor for about 20 years, and I can tell you that having been through chemo and radiation, I wish that there would have been biomarker testing back then. It might have prevented the secondary and third types of cancers that I've had. But on to arthritis, I know the question was asked earlier about this expanding past cancer. This is certainly relevant to all chronic diseases. For the 1.4 million residents in Maryland that have doctor-diagnosed arthritis, this is important not only for the diagnosis, but the management and treatment of their disease lifelong as you live with this condition. Given the complexity of arthritic diseases and the demographic impacts, understanding arthritis is the first step in managing it and managing it well. It's not a singular disease, and it can refer to joint pain or joint diseases, and there are more than 100 types of arthritis and related conditions. People of all ages, races, and sexes live with arthritis, and it's the leading cause of disability in the United States. In 2016, we actually surveyed and found that it takes an average of 2 to 3 drugs for a patient to become stable who is living with arthritis. And in the meantime, they're facing worsening disease and physical, financial, and emotional tolls that come with that. So symptom management is a key to preventing more severe diseases and long-term and resulting negative impacts. Biomarker testing is the solution for this, and we actually have 4 different types of current biomarker tests for patients living with arthritis, and you'll excuse my pronunciation of these, I'm definitely not a doctor, but polyglutamate testing actually measures methotrexate's effectiveness and can allow a doctor to adjust doses for patients. And then we have several others that can also affect RA and the management of those diseases. So I really appreciate the committee's consideration of this important legislation and encourage you to just be on the proactive side of medicine and make sure that we get precise care for patients living with all chronic diseases. Thank you so much for your time.
Thank you. Are there any questions for these witnesses? Seeing none, thank you all very much for your time, your testimony, and for your patience today.
Thank you, thank you, thank you.
We have 2 more virtual witnesses, Michael Weinstein and Lindsay Viscara. Lindsay, you want to go ahead? Nope, not there. There we go. Okay, Lindsay, you want to go ahead?
Absolutely. Thank you, Madam Chair and members, for your time today. My name is Lindsay Viscara. I'm the Public Policy Manager at the International Foundation for Autoimmune and Autoinflammatory Arthritis, or AI Arthritis for short. I'm also a person living with psoriatic arthritis and the caregiver to a child with 3 AI arthritis diseases. I say this by way of introduction because our foundation is entirely patient-led, giving us a unique perspective. Like Melissa said, many of our patients need 3-4 medicines to figure out one that works. They need 3 to 6 months to work. Biologics aren't 2 or 3 times. They're months and months, so it can take years for us to find the medication that works for us. And then those delays cause more joint damage, more organ damage. So to make sure that patients with our diseases have access to biomarker is a super game changer for us. Saves money for not only the patient, but for the health system as a whole. So I urge you to support HB 1217. Thank you so much.
Thank you. Thanks for your efficiency. Mr. Weinstein. You're on mute, I think? Yeah.
Can you hear me?
Yes, we can hear you.
Very good. Ms. Chairman and members of the committee, my name is Dr. Michael Weinstein. I live in Montgomery County. I'm a board-certified gastroenterologist with more than 37 years of experience, and I'm the CEO of Capital Digestive Care, Mid-Atlantic's largest gastroenterology group with more than 20 sites across Maryland. I also chair the Health Policy Committee of Maryland Patient Care and Access Coalition, a committee well known to this committee over the last 15 years. MPCAC represents hundreds of physicians in independent medical practices across the state, gastroenterologists, orthopedic surgeons, urologists, et cetera, and we care for hundreds of thousands of Marylanders every year. Over the past few weeks, MPCAC has been engaged on the topic of biomarker testing and the need for Maryland patients to have access through coverage in their health plans for these important services. Biomarker testing is one example of precision medicine that can make a real difference in patient lives. These are indispensable indicators of the presence and severity of disease. Biomarkers include blood proteins, antibodies, tissue immunological biomarkers, fecal biomarkers, and genetic biomarkers. As a gastroenterologist, we use biomarker testing to identify patients with higher risk and complicated inflammatory bowel disease, ulcerative colitis, and Crohn's disease. We found that the cost of biomarker testing is minuscule compared to the cost of managing complications or the annual cost of biologic medications. Just yesterday, and I mean yesterday, the American Gastroenterological Association released new clinical guidelines strongly recommending non-invasive biomarkers as first-line strategy for monitoring patients with ulcerative colitis. Tissue immunochemistry biomarker tests are also important in stratifying colon and gastric cancers. Higher risk patients can undergo more frequent cancer surveillance. We can save money and then avoid unnecessary costs through these saving resources. It's our goal to provide better care to Maryland patients, provide better care for the community, and lower the cost of care. We strongly recommend passing of this bill, HB 1217. We urge passage, and I'm available for questions.
Thank you. Are there any questions for Dr. Weinstein? Okay, seeing none. Thank you so much, sir, for your time and your testimony today. And that concludes the hearing on House Bill 1217. And we will go to the last bill of the day, which is House Bill 815. Delegate Fennell, welcome. And you have a panel, if they would come up.
Yes, ma'am. Madam Chair Collison and the HGO Committee, thank you. And I do have a panel. It's actually an honor to be in front of you all today. And my word for today is push. I am Delegate Fennell. I'm the primary sponsor of HB 815, breast and lung cancer. Establishment of screening awareness program, insurance coverage, and cost sharing. Thank you for this opportunity. We often talk about direct impact of the bills we sponsor and promote. This bill, without question or doubt, will save the lives of Maryland citizens when it becomes law. And before you, as a Black delegate, as a woman who raised suffer disproportionate from unjust and discriminatory healthcare system. But I'm also here as a breast cancer survivor. In fact, I'm still under doctor care. I was one of the fortunate ones who got early detection and treatment, but many are not so fortunate. Particularly for Black and brown people. I will never forget the day of my diagnosis. As I waited, I hoped and I prayed that I would be spared. But when I heard those faithful words, "You have breast cancer," my life changed forever. Once the shock wore off, I gathered myself for the fight. I promised myself and my God that when I walk through the dark night, I will emerge in the morning to help others afflicted with this terrible disease. But it is not enough that we focus on breast cancer. Lung cancer is the #1 killer in Black and brown and white people. Whether you are a man or a woman, it doesn't discriminate. If you're a Black woman, you stand a 40% higher chance of dying of cancer than a white woman. That is 40% higher. And please understand, my friends, these are not statistics that's from the state of, these are the statistics from the state of Maryland and not from Alabama or Mississippi. I have beaten this disease and I'm a survivor. And I am determined to make a change. Please resist the insurance companies and naysayers. For pennies, we can save Maryland citizens, particularly people of color, which are being mistreated in our current system. With me is my panel that is here. And I just want to say that I'm asking for a favorable in HB 815. And I thank each and every one of you. Push.
Thank you, Delegate. Thank you very much. Thank you for being here and thank you for sponsoring this bill. Go ahead.
Thank you so much, Delegate Fennell. Madam Chairperson, members of the committee, my name is Danielle Varanian. I'm an attorney who represents RadNet, and I'm here to urge a favorable report on House Bill 815. This bill has two main components to it. The first is diagnosis. The second is education. Although Maryland already requires that breast cancer screenings be covered completely by insurance, those screenings are meaningless without follow-up diagnostic studies. What this bill does is address that gap. And for women who are told that they need to come back for those follow-up studies, this bill provides coverage for that, for those test studies. Similar to the issue with breast cancer, lung cancer screenings are also currently covered, but the subsequent diagnostic studies are not. This bill addresses that issue and provides insurance coverage for those subsequent diagnostic imaging studies. Finally, the second portion of the bill is an educational portion, which establishes a breast and lung cancer screening awareness program. The purpose of the program is to provide education about the importance of the screenings and coming back for follow-up, as well as to address some of the stigmas associated with those screenings and diagnostic tests. Think smokers and lung cancer screenings. So again, thank you for your time, and we urge a favorable report on House Bill 815.
Thank you. Who will go next?
That would be me. Thank you, Madam Chair. Thank you, members of the council. Excuse me. Okay, thank you, members of the council. My name is Clefandra Brown, and I am here from RadNet, and I am in favor of House Bill 815. Social determinants such as lack of access to quality care. I will also say having the ability to afford the care, as well as having navigation to understand why the preventative care is needed, truly adversely impact a person's healthcare decisions. When it comes to understanding what you have and understanding how to navigate your health, you have to know what is important. And most people do not have the education or the understanding of why there's importance when it comes to healthcare and preventative care. The lack of knowledge necessary to understand the importance of preventative care causes an issue and concern. And the differences between a stage 1 and a stage 4 cancer is a delay in prioritizing one's health. And I will tell you, I know this personally because this has impacted me and my family. My mother's cancer progressed to stage 4 because of these very concerns. She does not drive, so therefore getting access to care is unlikely, as well as she does not understand the questions to ask because she is not always treated fairly because of healthcare disparities. And let's not even begin to talk about affordability. When you are on a fixed budget, preventative care is not something that you truly think about because if nothing's wrong, you don't answer the call. And then when you find something, you may not be able to afford to do anything about it. No one should have to decide whether or not they should pay their bills, eat, or afford health care. The truth is that we all deserve the right to live a long and healthy life, not only for ourselves, but for our family and our friends and our loved ones. So it doesn't matter where you live. It doesn't matter your socioeconomic status. It doesn't matter your education levels. It doesn't matter your gender. It doesn't matter your ability or disability. Everyone, and I mean everyone, has the right to have access to high quality, affordable, and equitable health care. And when underrepresented communities do better, we all do better. Thank you for the floor.
Thank you very much for your testimony and for sharing your stories. We really appreciate it. Next, we have Stacy King. Nice to see you, Delegate Fennell.
It's a pleasure to see you also,
Thank
Madam
you.
Chair. Thank you.
And good afternoon, ma'am.
Thank you, Madam Chair and delegates, for this opportunity to speak to you and urge your support for House Bill H15. My name is Dr. Stacy Keene. I'm president of the Maryland Radiologic Society, a diagnostic radiologist with advanced radiology specializing in breast imaging and a breast cancer survivor. Screening saves lives. There has been a 40% reduction in mortality from breast cancer in the United States since the initiation of widespread screening mammography in the late 1980s. In order to save lives and decrease medical expenses, we must find breast cancer early at its most curable stages and be able to act on these findings. My job as a breast imaging specialist includes looking for findings on screening mammograms suspicious for breast cancer and to pursue these findings with further evaluation as needed by additional mammographic views, ultrasound and/or MRI, as well as biopsy to confirm the diagnosis. Unfortunately, I have personally seen multiple patients decline or cancel the recommended studies because of the inability to pay for them. Some who eventually returned were diagnosed with cancer more advanced than would have been the case initially. More advanced cancers can lead to greater treatment costs and lower survival rates. In addition to being a breast imaging specialist, I'm a breast cancer survivor. My own cancer was found on a screening mammogram. I was able to promptly undergo the necessary additional mammographic views and ultrasound that led to my biopsy and diagnosis. Had those additional studies been delayed and my cancer not been detected at such an early stage, I might not be here over 20 years later. I know the anxiety of being diagnosed with breast cancer. The addition of financial concerns at the already highly stressful diagnostic time places an even greater burden, both emotionally and financially, upon patients and their families.
Thank you for sharing your personal story. We really appreciate it. Next, we have Lisa Mullen.
Thank you, Madam Chair and delegates. My name is Dr. Lisa Mullen. I'm a breast imaging radiologist at Johns Hopkins Medicine. I'm speaking in support of House Bill 815. The medical literature includes many studies related to disparities and delays in breast cancer care and how they're interrelated. Delays in follow-up after an abnormal screening mammogram and delays in obtaining a breast biopsy were found to be higher in Black women, Hispanic women, and Asian women. Delays in other follow-up imaging were more likely in Black women, those with Medicaid and self-pay status, and those living in low-income zip codes. The delays in every aspect of care are at least partially related to insurance coverage and the cost of follow-up testing, and these factors disproportionately affect minority women. Delays lead to decreased survival. A systematic review of the literature showed that patients with breast cancer treatment delays of 3 to 6 months had a lower 5-year survival than those with shorter delays, and longer delays were associated with more advanced stage cancers. Low-income breast cancer patients have 5-year survival rates that are 9% lower than high-income patients. Black women are 41% more likely to die from breast cancer than white women, and part of the racial disparity is due to more advanced stage at diagnosis and less access to high-quality treatment, likely due to financial barriers. When breast cancer is small and does not involve regional lymph nodes, it's easier and less expensive to treat, with fewer complications and better long-term survival. Helping women to understand the importance of screening and have access to diagnostic testing will improve patient experience and outcomes, decrease overall healthcare costs, and help decrease racial disparities in breast cancer treatment. Thank you very much.
Thank you very much for making the time to come here. We really appreciate it. Next, we have Kimberly, is it?
Oh, my goodness.
It's okay.
Wipe out the microphone.
At least you didn't turn it off. It doesn't like to be turned off, so
Okay, that's
it's
good.
okay.
Madam Chair, members of the committee, thank you for this opportunity to provide testimony in support of House Bill 815. My name is Kim Bathurst. I work at RadNet in Maryland. You know us as American Radiology, Community Radiology, and Advanced Radiology. RadNet is the largest provider of screening mammography in Maryland. I've dedicated 36 years of my professional career to early detection of breast cancer as a radiologic technologist with certification from the American Registry of Radiologic Technology in breast imaging. I oversee the department that tracks all suspicious findings from screening mammography. I tell you this because I see the problem with patient compliance and follow-up for breast imaging every day. Our Maryland data showed over 33,000 women needed to return for additional imaging from screening in the year 2022. Sadly, in 2022, about 1,600 of those patients needed additional imaging that did not return. They either refused, wouldn't answer our phone calls or messages, ignored text, certified letters. And this is where I think we all need to keep saying and hearing one statistic. 1 in 8 women will develop breast cancer in their lifetime. Other words, from our data, 200 possible breast cancers undiagnosed right here in Maryland. Let me add that approximately 50% of those women who also had a suspicious finding identified as Black, Hispanic, Asian, or another minority race. Affordability is a significant barrier to compliance with follow-up of diagnostic imaging. Within the last 2 weeks, my team spoke with at least 26 patients who bravely admitted they couldn't afford to come back in for additional imaging from their abnormal screening mammogram. One patient noted, "I just don't have $200 to $300 like that." Another patient commented that they were about to lose their job and $500 owed was not affordable. She'd call us back when she had a new job. My team noted that most of these 26 women did not schedule their follow-up appointments and had similar comments. House Bill 815 will be life-changing for many Marylanders, especially those of minority, low-income, high-deductible insurance plans. House Bill 815 will allow patients to receive their additional imaging without worrying about financial burdens. And not only does House Bill 815 set a standard for many other states to follow, but your vote in favor of this bill will save many lives of my fellow Marylanders.
Thank you very much for your testimony. Really appreciate it. We have a virtual witness, which is Ms. Bettina Straight. Will you be so kind and allow her in? Good afternoon. Will you be so kind and unmute yourself?
Yes, thank you. I
Welcome.
appreciate it, Madam Chair.
Yes.
My name is Bettina Straight, and I am the Chief Inclusion Officer at So Others Might Eat in Washington, D.C., and a Maryland resident who is also in her second year of breast cancer treatment for triple-positive breast cancer with lymph node involvement. I'm speaking in support of House Bill 815, and anecdotally got a text message from my mother literally half an hour ago saying her mammogram from earlier today was clear. On October 29th, 2021, I found a lump in my right breast and saw that there was an indentation in that location. Having seen illustrative materials in waiting rooms over the years, I knew that that was not a good sign. What compounded my fears was the fact that on that day, I did not have health insurance. I started my new position at SUM in mid-September, and because of their waiting period, I did not have coverage until Monday, November 1st, and considered myself incredibly fortunate. Had I found it any sooner, however, I would have been faced with the decision that so many women have. Can I afford the tests I'm going to need, and can it wait? When I went back to my medical health records and tallied up the cost of the mammograms, ultrasounds, biopsies, scans, and lab work, I found that between November 8th and November 19th, just 11 days, my medical costs were well over $10,000. Because of the aggressive nature of my cancer, my tests and appointments happened very quickly, leaving little time for consideration of what could and couldn't be covered. And it was overwhelming enough to suddenly be faced with my upcoming chemotherapy, surgery, radiation, more chemotherapy, and hormone blockers. And because of my insurance, no one really discussed the costs associated with each procedure. When my explanation of benefits came, however, that's when I saw the actual price of being needed. Having diagnostic evaluations covered as part of the course of care would absolutely provide better physical outcomes, and just as important, allow patients to focus on their path toward healing. Thank you.
And thank you for sharing your story. We really appreciate it and happy for you and your mom.
Thanks.
I'd like to call on next Ms. Chen Ting Ling. Oh, Mr. Chen Ting Ling, I apologize.
No worries, thank you.
Suits me well for making assumptions. Go ahead.
Actually, it's Dr. Cheng.
Dr. Well, you know what? Guess what? I will call you Dr. Chen Ting Ling. You know why? Because you earned it. That's a lot of years in school. So, doctor, welcome to the health committee, doctor. Enlighten us with your knowledge.
Thank you so much.
Our pleasure.
Madam Chair and member of the committee, I am humbled and honored to be here to speak to you. Again, I'm Cheng Ting Lin. I am an associate professor of radiology at Johns Hopkins Hospital, and I specialize in lung cancer imaging. I'm here to present my own views on, in support for HB 815 regarding breast and lung cancer screening. So I can sit here, tell you how devastating this disease is, but I feel like my fellow panelists have done such a great job with that. So I'll just share with you, I've been speaking with one of my fellow very good pulmonology colleague, Dr. Galicedos. He took care of this 80-year-old gentleman who was retired, he was Black, he was in a robust state of health. He expects to live for another decade or more, and he smoked. So he agreed to undergo lung cancer screening CT, which, as you would expect, found a suspicious lung nodule, which led to another test, which led to another consult. It all adds up. And after a challenging 8-month, what do you think happened? I mean, thankfully, the story has a good ending. He had a pretty good health care insurance from his status as a veteran. And so as of last month, he's cancer-free. We need more success stories like that. We need more screening done in the younger population who we know are under-screened. We need more screening done in minority groups. We need to bridge the gap, and we can change the narrative on lung cancer outcome that way. So thank you.
Thank you, Dr. Tinley. Really appreciate your testimony and your expertise. You know, it gives us perspective. Laura Lee, Ma? How are you? Nice to see you again.
Nice to see you again as well. Madam Chair and Vice Chair and members of the committee, thanks for having me back again. I am Lorelei Ma. I am the immediate past president of MedGuy, and I'm a past president of the Maryland Radiological Society as well. I was actually the first woman president of the Maryland Radiological Society. I am a private practice radiologist working in the suburbs of Baltimore and Howard County, and I am speaking in support of House Bill 815. We've already heard from our physician colleagues and our patients who have given their amazing stories, even in other panels today, how screening saves lives. We've also come to understand better during COVID how not everyone has equal access to health care, including screening examinations. Lung cancer, as has been said, is the leading cause of cancer deaths for men, women, Black Americans, and every ethnic group in this country. A really underserved, underappreciated cancer in terms of funding and coverage. Lung cancer screening has been shown to be effective and can decrease death rates from lung cancer by up to 20%. But that's only if the patient gets the screening test. In Maryland, only 7% of eligible people who could have free lung cancer screening take advantage of it. We need education so that people know this exists, awareness and access for our patients. They need to have access to areas that they can get to, right? It's not just knowing that it's there. Maybe they need a bus to get there. They need to know that it's available. Once a patient has an abnormal examination, however, the copays and the deductibles for the follow-up testing and biopsy are currently not covered, even if you have health insurance. And that's why that payment comes. All of a sudden, you think I'm covered, but then you get that big bill. Until an abnormal examination can be further worked up, and finally with a tissue diagnosis, the patient will not know whether he or she has cancer. For some of us, as has been noted, this cost is an inconvenience. However, for many of us, it's either not attainable or comes at a cost to the family. That really should not be the case. Every American deserves access to screening exams and the follow-up testing, including biopsy, that can save their lives. Advances in lung cancer treatment have now made a stage 1 lung cancer have a 60% 5-year survival, and patients in the screening programs, 80% 5-year survival. That's a huge jump. We need to catch it early so patients can have that opportunity. Finally, a cancer caught early is less expensive than a cancer caught late. Not just in monetary terms, though, but in human terms. Cancers don't just affect people, they affect families. The worry, the morbidity, the loss of income, or the ability to care for family members, their children, their parents, are all part of the greater cost when patients aren't able to have access to screening and the follow-up examinations to determine whether or not they have lung cancer. I urge a favorable report, and thank you for listening.
Thank you for your time. Really appreciate it. I have one more person. This is from Stephen. Yes. Fort Harper.
Fourth Huber.
Yep.
Thank you,
How are
Matt.
you? I said, how are you?
Very good. How are you?
I'm doing well, thank you.
Good. Thank you, Madam Chair and the committee for this opportunity to provide testimony in support of House Bill 815. I'm Steve Fourth Huber. I'm the President and Chief Operating Officer of RadNet and a Maryland resident. As you heard, you probably know us better through our partners at Advanced Radiology, Community Radiology, and American Radiology. Together, we are the leading providers of both breast and lung cancer screening in the state of Maryland. As you've heard, just to reinforce, the purpose of House Bill 815 is to save lives. And we're going to do that through better education of the benefits and the needs for screening, lung and breast screening, and also through the elimination of barriers to the follow-up, the necessary follow-up care that's caused by such things as out-of-pocket expenses, health inequities, and also some of the stigmas that are associated with these cancers. Over 3,000 Marylanders will die each year from breast and lung cancer, and as you've heard, lung cancer is the deadliest of these. You've also heard testimony that we've made great strides with lowering the mortality rate for breast cancer through screening mammography. But very sadly, the same cannot be said about lung cancer. There's only a 7% compliance for eligible lung cancer patients in Maryland right now. That is deplorably low, and that leads to diagnosis of late-term cancers. We really can, should, and must do better than that. Simply put, early detection saves lives. Early detection also saves money for everyone involved, and that includes the insurers, the patients, employers, and the overall healthcare system in the state of Maryland. The difference between a stage 4 and a stage 1 breast cancer diagnosis is fivefold, about $180,000. And the difference for lung cancer is threefold, roughly $94,000. The Maryland Healthcare Commission has estimated that the waiving the cost share for the breast screening supplemental will only add 83 cents to the premiums for the privately insured, and we believe our bill will have a similar negligible impact. So in closing, we hope that you'll join us in supporting our bill. We want to ensure that everyone in Maryland has equitable access to high-quality, affordable health care so we can detect both breast and lung cancers as early as possible. Thank you.
Thank you for your testimony today. I appreciate it. Now I'm going to open it up for questions. This was all a favorable panel. Are there any questions from the committee? I'm going to start first with Delegate Chisholm.
Thank you, Madam Chair. Just a
My
quick
pleasure.
question. You said only 7% follow up with compliance. Can you expand on that?
Well, for the eligible guidelines that exist from the USPSTF, only 7% of the Marylanders who meet those guidelines are actually getting screened today. And this speaks to the need for greater education, greater awareness for why these patients should be screened in the first place.
My pleasure. Delegate Taveras.
Thank you. So, Delegate Fennell, my question that I have is, do you think a support group for cancer survivors, kind of like Hope Connections or these types of groups, if that would have been helpful getting you through the process?
Delegate, any type of support group that is out here that can help in reference to getting through this process, yes. But in dealing with what you see the panelists talked about, I seen the faces when I went to chemo and I went to radiology in reference to people that could not afford it and did not come back. That hurt me because I was able to come back. I am a survivor. I still receive calls from your area. I met a young lady. She could not afford it. And I'm trying to help her the best way I can, but she's not the only one. This is the reason why we bring this bill in reference to any type of help that we can get to make sure that they can get the treatment and screening that they need. We need to do so. And I hope I answer your question.
Thank you. And Delegate Riley.
Thank you, Madam Chair.
My
I was
pleasure.
looking, does the bill state in there, like, how often this can be done, or an age limit or somewhere, or is it just anytime if you feel like you need to go get checked?
Delegate, what the bill does is it's consistent with the standards of care of medicine. So it provides that when a physician or an appropriately qualified provider says that this diagnostic study is necessary and you need to come back, that's when it would be covered. It does.
My pleasure. Any other questions? Seeing none, I just want to thank the delegate. Thank God you're doing well, and thank you for sharing your journey. And we send prayers for you for continued healing, okay? And for everyone else and everyone that shared their stories, thank you for doing that with the committee today. We appreciate you and your time, and we send you prayers for healing. We have now a favorable with amendment bill, and it's actually, testimony is Matthew Centellano from the League of Life and Health Insurers of Maryland. And I'm pretty sure he's gonna have good news for you. Which is usually not the case, let me tell you.
Third time today.
Gonna go play the lottery. Go ahead.
Madam Chair, members of the committee, Matt Celentano here today on behalf of the League of Life and Health Insurers of Maryland in support of House Bill 815 with amendment. We want to thank you for the opportunity. The carriers are all supportive of this bill. The only thing we would like to point out is that House Bill 376 passed earlier this session is actually passed out of the entire House of Delegates, which covered diagnostic testing for breast cancer. There might be conflicting language in this bill, and we just suggest that we conform the two bills to make sure that we don't duplicate. And that is it. Thank you very much for the opportunity.
Thank you, I appreciate it. We have an amazing lawyer right here to my right, so
I'm aware, yeah.
I'm sure she was gonna do that, but thank you for suggesting it. That's great, a great suggestion. Are there any questions for the man who's bearing gifts today? Seeing none, thank you very much, okay?
Thank you.
My pleasure. Actually, this concludes the bill hearing on House Bill 815. Thank you so much for coming, and you have a blessed day, okay? I thought I saw Prince George's County State's Attorney come in, but Aisha Brayboy, give her my love. I know I saw her come in. So for the committee, this concludes our work today. And if you could just stay 1 second after we are done, okay? Thank you so much. You can take us off, please. We're done. Right? Thank you for doing those two bills. I appreciate you. Thank you. Just 20 more seconds to go off. That's wonderful. I was worried about it. Okay. Good.